Please note the information presented is for informational purposes only and does not substitute professional or medical advice or medical consultations with healthcare professionals. We have about 5 minutes for Q&A at the end of every presentation, so please be sure to hold your questions until the end of every session. For those in person, the restroom is located just down the hall to your left when you exit this room, and there are also signs pointing to the restroom in case you have trouble finding it. And lastly, if you parked in the structure, you can request parking validation at the front desk in the lobby. But without further ado, I'm pleased to introduce our director. Dr. Rachel Bergmans is a research assistant professor of anesthesiology at the University of Michigan, where she leads the Chronic Pain and Fatigue Research Center's publicly engaged research core. Dr. Bergmans focuses on developing models to increase public engagement in research with the goal of addressing inequities in pain care to benefit everybody. She is joined by Lisa Thomas, a Lupus Warrior and event coordinator for Lupus Detroit. Please welcome Dr. Rachel Bergmans and Lisa Thomas.
Good morning and welcome to our 4th annual Lupus Conference. My name is Rachel and I'm here with Lisa Thomas, and we're so glad to see all of you here today, both in person and online. Whether you are someone living with lupus, a caregiver, a healthcare professional, an industry representative, a researcher, or a community member, thank you for taking the time to join us today. I want to give a special thank you to our Community Advisory Board for Lupus Care and Research. Your partnership and insight have truly shaped this event and the work we do all year round. I also want to recognize the organizations and groups who are attending the conference with booths and tables, including the Michigan Lupus Foundation, Mothering Justice, Lupus Detroit, and Transition Well. And I would like to thank our sponsors for the event, including the Department of Anesthesiology at the University of Michigan and AstraZeneca. Please take some time during the breaks to visit the tables in the Dearborn room next door, pick up resources, ask questions, and connect with these supportive groups and organizations. There will also be more dedicated networking time at the end of the day, so you will have another chance to meet with representatives and continue your conversations. Sorry, where's our... Here we go.
This conference is an extension of an ongoing community engaged research program, which began 3.5 years ago when Lupus Warriors collaborated with Rachel and others at the University of Michigan to create conquerlupus.com. This is a freely available website for people to learn about lupus and to find practical strategies for managing lupus symptoms like pain and fatigue. As a lupus warrior, 3 things that are important for me that I like to share with people is the time of diagnosis. It can be quite lengthy. I think the average now is about 7 years to diagnosis. I had symptoms as early as 20 years ago. It took a while to be diagnosed because lupus is similar to so many other things. I would say that if you believe that something is going on with you, continue to press forward, see your doctors and get advice. Another thing that I like to mention when talking about it is living with lupus and the challenges that it brings and how we change from day to day. It's not a cookie cutter illness. Each one of us experience signs and symptoms differently and even respond to different medicines differently. But I would advise you to listen to your healthcare professionals and their words, take them into consideration, but you are your boss of your body and your healthcare, and you can fire them at any time if they are not in line with your health. And lastly, another important thing to me is community, having a community, surrounding yourself with positive people, having a support system, whether it be family, friends, or fellow warriors, even healthcare professionals can be a shoulder to lean on. And so that's what I'll share with you about that. So our purpose today is to share useful information and learn from one another and make lupus care better together.
Here's a snapshot of our day. We'll start with strategies for treating lupus flares, followed by the latest in clinical trials and new treatments. We also have powerful sessions planned on lived experience and patient advocacy, as well as dedicated time to talk about chronic pain management. There will be a focus on lupus and maternal health, a yoga therapy session for everyone to try, and a panel featuring caregivers. We hope you find these topics relevant and helpful, whether you are seeking the latest research, practical advice, or just some encouragement from others who understand what you're going through.
We are especially excited this year to feature stories from a documentary photography project. Over the past year, we have worked with a professional photographer to capture real stories of lupus, including loss, community, resilience, and hope. I encourage you to take the time to view these images and reflect on the journeys that they represent. Another special feature is our Lupus Remembrance and Celebration Wall. At any time today, you are welcome to honor or remember anyone affected by lupus by adding their name or message. You can take photos with the wall and share them if you like. It's our way to connect, celebrate, and remember together. Do your best to make the most of today. Please ask questions, share your thoughts, and get to know the people who are around you. Each person in this room brings an important and lived experience, and together, this makes us stronger.
Before we move to our first session, I want to let you know about two opportunities that came directly from our community conversations. Many of you have told us that chronic pain is a daily challenge. In response, and with guidance from the Community Advisory Board, we are launching a new research study offering a health coaching and yoga-based program for lupus chronic pain. The MyPal study lasts 13 weeks and involves 5 coaching sessions where participants work with a health coach and a yoga teacher to develop an individual symptom management plan. Participants will also complete surveys related to their background, symptoms, and experience with the MyPal coaching program. Findings from this study will help improve research on lupus pain management and intervention development. Volunteers will receive up to $100 for participating in all study activities and are fully remote. If you're interested in learning more about joining the study, please visit our information table where you registered or talk to one of our PERC team members. Your voice and your experience are vital to this work. Additionally, we're also conducting a survey study to learn about physical activity and lupus and how someone's health and environment impacts their quality of life. The questionnaire study is administered in 3 parts, and participants are compensated up to $60 for completing the study activities. You can learn more using the QR code on the slide or by visiting the TPAL booth led by Dr. Dom in the room next door or emailing our team.
Thank you again to everyone who made this conference possible, from the planning committee to the volunteers and each of you who took the time to be here. We hope you find today valuable and supportive. Let's get started.
Thank you.
Yes, sir, please. Great, thank you. Our first presenter today is Dr. Michelle Kallenberg. Dr. Kallenberg is an associate professor of internal medicine and rheumatology at the University of Michigan. Her clinical work involves providing care to lupus patients, and her research focuses on uncovering factors that drive lupus flares and the development of complications. Please welcome Dr. Michelle Kallenberg.
Everyone, good morning. One new title that I've just taken on starting in July of this year is I'm also the new director of the lupus program at the University of Michigan. So I'm very interested in feedback on how the university's lupus care team can also help the community. We have a lot of reform that we're trying to do, including improving our access, but I'm very open to suggestions. So please feel free to reach out to me if you have ideas. I was asked to talk a little bit about lupus flares. And so, first of all, I like to play with AI, and we have this U of M chat GPT, and I said, show me a picture of a lupus warrior. This is what it came up with. So I really think like we should get these headbands going. It's a good look. It's a badass picture. It's good. You know, and I think there's only 5 fingers on each hand, so it did a good job. It didn't do anything weird. Okay, so let's talk a little bit about what is lupus. So a lot of you live with lupus, you've experienced it firsthand, but you know, how do we define it? And it's really one of the most interesting autoimmune diseases because it really affects every part of the body. You know, there's certain diseases that just affect the liver or just affect the thyroid, but lupus is one where any organ is fair game. And the most common places for it to affect are skin, joints, and the kidneys, but it can do brain, it can do bone marrow, it can do muscle. And this is just a picture here of all the different places where it can go. Why do people get lupus in the first place? It's a good question, and we still don't fully know the answer, but we do know there are genetic risks, and a lot of people have lupus that runs in their family, unfortunately. So we know there are certain parts of our DNA that contribute, but it's not just about the genes, because you can have the genes and you don't necessarily get lupus. And we know that there's an important interaction between environmental factors. And this isn't just, you know, the trees and the nature. This is the food you eat, the stress you experience, the pollution you live in, you know, all of the things that add up and can constantly, you know, ping your immune system to misbehave. And those things over time, eventually we have different parts of our immune system, but they push on what we call the innate immune system. And this is like the early responder type of immune system. And it turns it on over and over again. And eventually this leads to tricking the immune system into attacking yourself. And this can go on in these cycles. And every time it repeats where you get symptoms, we call that a flare. As I mentioned, it can affect, you know, many different organs. And this is one of the things that makes lupus hard to diagnose because no 2 people present the same. And it also makes it trickier to treat because certain medications are better at treating certain manifestations than others. And so we really have to take into effect the whole picture of what's happening with a patient at that given time to determine what we think are going to be the best ways to improve the lupus. And this is one of the things that, you know, is a little bit unique to lupus, and that lupus activity comes and goes. And there's sometimes where you feel okay, and then there's sometimes where you just don't. And, you know, this coming and going, it starts as a predisposition. We know you have lupus, but then there's always this something triggers it, right? So we think about these of triggers of flares. I like to think about it like a light switch where something comes along and you're doing fine and it just kind of knocks you off course. And then suddenly you're not okay. And so these light switches are really important because we want to try to identify them and prevent them so that you don't end up in flares. But, you know, when we get a flare, you know, up until very recently, we mostly just had hammers to turn it off, and that was steroids, right? So the way we've treated lupus for 50 years plus has been suppress the immune system. Now we're getting to the point where we're getting newer drugs online that can be a little bit more meticulous, and we'll kind of talk about that. And, you know, one of the reasons it's so important that we try to get better about being very specific when we're treating flares is because the side effects of things like steroids are high. Infection risk, you know, drugs can make you feel not so great sometimes. They can cause GI upset, other things. And then the cost of drugs becomes a problem, right? And this, I think, with all of the wonderful changes that are happening in our administration right now, we see that healthcare insurance seems to be much more willing to be rejecting covering drugs these days, pushing copays onto patients. And so just being able to get a drug affordable for a patient has become a harder thing to do. And so the other thing that's challenging sometimes when we think about treating lupus is that a patient may not look the same every single time they get sick. So, patient of mine recently had been doing great. We had her on 3 different medications, finally got the steroids down, and then all of a sudden, for no reason, platelet count drops, and now she's like bleeding because her platelet count is too low. Never had a problem with her platelets in the 10 years of lupus, right? New thing. So this happens sometimes in lupus where, you never present the same way. I mean, sometimes your flares can be similar, but sometimes they change. And so we always have to be ready and watching to make sure that we can pick up if something is changing about the lupus and maybe we need to change the treatment. And so you can go from just having kidney disease to suddenly having issues with chest pain, etc. And again, we want to try to tailor the treatments of flares to the types of symptoms that you are having. And with some of the medications that are now approved, but also newer medications coming up through clinical trials right now, I think 5 years from now, maybe even sooner, we're going to have a larger number of treatments available to try to fix various problems that exist in lupus. So what's our approach to treating lupus in general? So we have some Band-Aids, this is how I like to think about it. So we have some things that can cover up symptoms. And these are our quick-acting medications. So this is things like ibuprofen, anti-inflammatories, and then steroids. And we're going to talk more about steroids in a little bit. But these are things, they don't really fix the underlying problem. They're just covering up the problem temporarily. So those are our Band-Aid drugs. And then we have longer acting medications that change how the immune system is functioning. And so one of them is hydroxychloroquine. And I like to think about this like, somebody who's meditating, because what hydroxychloroquine does is it calms the immune system down, but it doesn't shut it off. So it's able to take signals from triggers of flares like viruses, bacteria, other things, and change the immune system's response so that it doesn't overdo it. And that's why hydroxychloroquine is added to basically every single patient. And we don't necessarily use it to treat flares, but we want to make sure that it's on board. So if you can tolerate it, and some people can, but if you can take hydroxychloroquine, we want it on board because it has this calming effect on the immune system without suppressing it. So there's no hammers involved. It's just chill. But then we also have these other medications that we think of more as immunosuppressants. Sometimes you'll hear the word DMARD, which stands for disease-modifying anti-rheumatic drugs. So sometimes we throw that DMARD term around. So if you hear it, that's what it means. But it basically means something that's going to suppress the immune system. And these are the 3 most common that we use in lupus. So mycophenolate mofetil, it's called Cellcept, or there's a cousin of it called Myfortic, methotrexate, and Imuran. And the way that all of these work, I like to think of them as the hammer. They basically stop the immune system from replicating. And so your T cells and B cells, the things that create those immune responses, they get killed off. So they stop them from replicating, they can't respond. And that's how it works. So it calms the lupus down because you kind of do this to it. But, but it's not, it's basically a hammer and it's stopping them from replicating. And then we have some newer drugs, and some of you have probably tried them at this point. Belimumab has been around, I think, for 12 years now. Anifrolumab has been around since 21. But these biologics, I like to think of them more as like a scalpel. They go in and fix very specific things that are going on with the lupus. So belimumab targets the development of B cells. And we know that in lupus, there's a protein called BAFF, which is too high. And BAFF pushes your B cells to develop very quickly. And so by blocking that with Benlysta, we can stop new autoimmune B cells from forming. So Benlysta works really slow. It takes 6 months to get to its full effect. But once it does, it works for some patients, and some people feel really good on it. And so sometimes we start this if you're having a flare. This is either IV once a month or a shot once a week. And then there's anifrolumab, the brand name is Safnello. And that is right now in IV monthly. There's clinical trials going to test the sub-Q form, and those are in late phase 3. So hopefully within a year or so, we might be able to offer a shot of Safnello as well. And so this drug, the way it works is it blocks a protein called type 1 interferons. And interferons are high, especially in patients who get skin disease. And so Safnello has been really a game changer for patients who've had bad discoid lupus that just hasn't responded to anything else. I have seen patients just completely clear with this medication. Now, nothing is without, risks and benefit discussions, right? Because all of these drugs, do suppress the immune system. And with Benlysta and anifrolumab, we sometimes see more infections more commonly or sometimes lasting longer. And with Safnello, because it works on a system, the interferons also are what help us fight viruses. We have to, make sure people are vaccinated to shingles. And if they get cold sores, we want to make sure that they have protective medication on board. But these are basically what we have. And if I come back and give you this talk in 5 years, I think this list is going to be a lot longer. There's a lot of stuff in phase 3 right now that looks very promising to get approved. So hopefully we're going to have a lot more options, especially for things that are more targeted with fewer side effects than some of these drugs where we're just hammering the immune system. Like I said, sometimes there's certain situations, certain organ manifestations that we pick different types of medications for. So Cytoxan or cyclophosphamide, this is our I put the picture of the cannon here because this is the biggest gun we've got when it comes to lupus. So this is when we pull this out when lupus is really bad. People are hospitalized from their lupus. Their kidney inflammation is really bad, when they have brain inflammation from their lupus, or they've tried all the other things and nothing is working. Then we go to Cytoxan. And this is an IV. You can either get it once every 2 weeks or once a month. And depending on how you dose it, you end up getting it over a period of 3 months to 6 months. This is really immunosuppressive, so you have to be very careful. You have to get monitoring labs when you're taking it. And we also, then you get monitored lifelong, basically, because it does increase your risk of having bladder cancer down the road. Usually that's only after you get this multiple times and multiple courses. So you have to get like over 10-gram exposure for that to be a concern. But it is something that we'll keep an eye on forever if you ever get this medication. It also can affect fertility. So we try to protect people's ovaries when you're on this medication. You get a drug called Lupron, which turns your ovaries off. Because the way this works is it basically kills replicating cells everywhere. And so your ovaries are someplace where your eggs are replicating, right? That's how you make eggs. And so we want to shut that process down while you're on the Cytoxan so that it can't affect, because if the cell's not dividing, the Cytoxan can't affect it. So we like to turn off the ovaries and put people into sort of a temporary menopause when they get this drug so that when they're done, we can let their ovaries wake back up and then they'll still work. So there's lots of side effects and things to consider when you're on this. We give you lots of pills to mitigate side effects when you're on this. And so we don't like to use it unless we have to, right? But if we have to, we have to. And hopefully the use of this drug will keep getting less and less popular as we continue to get better about more targeted scalpel type therapies for our lupus. And then there's some other specialized drugs like voclosporin or one of its cousins, tacrolimus, which we use sometimes with certain types of kidney disease in lupus where you have a lot of protein in your urine. So if you have a lot of protein, this is also often added when you're getting treated for kidney inflammation and lupus. So those are kind of the drugs that we have. And that one is very targeted, right? We only use that in special situations. And so, we have some rules that help us decide when to use what, but there really is an art to treating lupus still. There's no algorithm because every patient is different and we really have to consider all the things about a patient, right? What does the patient want? Do they want to take a pill? Do they want to take an IV? Like how much medication does the patient want to take, right? This is a discussion that we need to have. And then, the severity and like how sick somebody is really kind of determines what drugs we tend to recommend. So this was a consensus put together in 2024, and this was based out of European guidelines, but we've been sort of following this here as well. And we kind of chunk lupus into mild, moderate, severe, depending on like how many organs are involved and how badly the inflammation is in those organs. And then, basically everybody gets Plaquenil. You can see that green bar across the top. So the HCQ, that's the Plaquenil. Everybody gets it if you can tolerate it, like that's standard of care. And then we sort of mix and match all these choices of all these other medications I just told you about, depending on what's going on. But I want to sort of mention some of these gray bars over on the side, because these are the things that people forget about, which is we also have other things that we need to do besides medications to help lupus patients get better. And we're going to talk a little bit more about some of these things, but exercise, sun protection, quitting smoking if you can, diet, making sure that you avoid infections with vaccines, working on your body weight, trying to keep your blood pressure under control, making sure your cholesterol is under control, making sure if your blood sugar is high, that's also getting treated. So there's lots of other things besides just giving drugs that really go into the care of lupus. Then if you have kidney disease from your lupus, we have a different algorithm because we consider that to be more severe. And so here, we look really at either giving Cellcept or cyclophosphamide, plus or minus belimumab, or plus or minus voclosporin. So that's kind of the new treatment algorithm for lupus nephritis when it's active. And then I just popped up this new drug here, obinutuzumab. So this is one that just reported a phase 3 study in lupus nephritis that had pretty positive results. And so we're waiting for FDA approval of obinutuzumab as well to possibly add to how we would treat lupus nephritis. And if anybody's ever heard of the drug rituximab or taken rituximab, it's sort of a cousin. It's much more aggressive in terms of like the spectrum of drugs. I would put this somewhere between like a hammer and a cannon. But it basically depletes B cells, and it does it better than rituximab. And so it seems to be giving much better results in the kidney inflammation. We don't have a lot of data about other aspects of lupus yet. There'll be other studies coming out, and whether it has any effects in the brain, we don't know. But I think this is going to be one of our newer drugs that will start to come online. And we're already using it in some situations already in the hospital at University of Michigan. So when we think about a flare, the way I think about it is really a change in lupus disease activity or how a patient is feeling or functioning related to their lupus. It's not always just about what we can measure, but I think it's also about how you're feeling and how your lupus is going for you, right? And it's never a straight line. So I pulled this out, just like show me pictures of like changes in the road, right? So this was a picture I got. But you think about your lupus, you're kind of on track, and then something, you're trying to get to remission. That's always the goal. Something happens and knocks you off course. And then, we kind of take a new turn and we're working towards remission. Something can happen and knock you off course again. So I feel like this is the path that we're going. And the flares are when we change direction in the wrong way. And why do patients flare? I kind of hinted at this light switch question, like what are the things that can sort of knock lupus off kilter? And really, it's anything that can trigger your immune system. But it's not just infections, which is like the most common thing that we think about. So you get a virus infection and all of a sudden your lupus goes haywire. But your immune system is affected by a lot. It's not just about the bugs. So stress, there are so many studies now that show that your nervous system is directly connected to your immune system. Most of that connection happens in the gut, believe it or not. But there's so much, there's such a role for stress in triggering lupus flares. I can't tell you how many patients I've had that get a divorce, somebody they love dies, their kids having, mental health crisis, and their stress levels through the roof, and then their lupus goes haywire. So I have seen it firsthand multiple times that stress can impact lupus. And so figuring out stress management is such a critical thing. And I think the work that Rachel and her team are doing with Dom and everyone else to offer life coaching, health coaching, stress management skills, it's so important for lupus. Physical trauma is another. You get in a car accident and your lupus flares, right? Physical trauma is such a stress on the body, and it's definitely going to trigger your immune system. So that could be another reason why patients flare. Lack of sleep is another important one. There was a study that was done where they were looking at people who had positive ANAs and what was the number one risk factor that would predict whether somebody would eventually get lupus or not. And the number one risk factor was whether or not that person was sleeping more or less than 7 hours a night. And so we know that sleep is important. And when you don't sleep, you don't feel well, you feel more stressed, and there's a bit of a vicious cycle in there, right? So sleep is super important. Poor diet can also be a trigger. High sugar processed foods, they interact with our gut in ways that make our gut unhappy, and our gut can then talk to our immune system and stress it out. So diet is really important. And then also just microbiome shifts. Sometimes you get a bout of diarrhea from whatever, but your microbiome gets screwed up in your gut, and then that can also talk to your immune system. Remember, there's this huge crosstalk there. And so microbiome shifts can also play a role. And the other one that I'm interested in, we do a lot of research in this, and if anyone's ever donated a skin biopsy to one of our studies, I'm internally grateful, but we know that UV light exposure is also a really important trigger. We've been able to drill down on why that is, and we think it has to do with the interferons, which are those chemicals that Safnello targets. But the interferons that are high in lupus patients, they actually predispose UV light exposure to become inflammatory. So I don't know if you ever had eczema as a kid, the doctors used to say, go outside and get sun because sun's anti-inflammatory. And so we'd stick all these kids with eczema out in the sunshine. But if you have lupus, that's a toxic thing to do because instead of it being anti-inflammatory, your lupus actually transforms that sunlight into an inflammatory signal. And it doesn't matter what your skin color is, whether you can sunburn or not, it doesn't matter because the UV light will still be an inflammatory signal to your skin. And if you want to know the biology behind that, I'll geek out and talk about it. So you can ask me later. But it's actually, I think, really interesting. So these are the most common things. I'm sure there's others. Everyone's different, right? But these are the important things that we really want to focus on because we want to try to prevent flares. And so these are the things we want to try to mitigate. This is the other one. Sometimes mismedication, and it's not always patient's fault, right? Insurance companies screw this up for us all the time. But if you go off your meds, sometimes your lupus will flare. So how do we treat them? So, I went through a bunch of meds, but I think there's really 3 important concepts that we need to think about anytime somebody has a flare. One, not every flare needs steroids. So I think that's a really important message. And this is something that the lupus community is really trying to get a handle on. And I'll show you some data about why steroids are just not a great solution. Number 2, medication is not the only answer. So I just showed you what all the triggers are. We have to think about things beyond just pills that can help our immune system calm down. And so it's really important to add those things in. And then number 3, you really have to let your care team know if you're not feeling well. Nothing makes me more distressed than a patient shows up and they've been not feeling great for 2 or 3 months. And they're like, well, I didn't want to bother you. I was like, well, I assume you're fine if you don't talk to me. So you got to let me know so that we can make a plan, right? So you have to let your care team know. And so we can help you get through whatever's going on. And one of the important things that your care team needs to do is do an evaluation for the flare. So we need to check your labs, right? I know getting poked is like not the best part about having lupus because we do a lot of blood work, but it's really important because lupus, like I said, it can show up one way and then the next day it's doing something else. So we always have to check, make sure your organs are okay, make sure the lupus isn't causing anything new that we need to change therapy for. And then we can also rule out other reasons why you might be feeling bad, right? It might not be your lupus. It's not always lupus. Do you have an infection hiding somewhere? There can be like slow acting chronic infections that can sneak up on people. Do you have a yeast infection in your esophagus? Do you have a fungal infection somewhere? Do you have tuberculosis? Like these are things that we look for anytime somebody's having not feeling well. Are you pregnant? Like sometimes people forget that like other things happen in life, right? So that's always an important thing to check. I mean, if you're a guy, we probably won't send a pregnancy test, but that's something that can happen. Sometimes it's just a flare of fibromyalgia, right? So is it lupus? Is it fibro? That can sometimes be a hard thing to sort, but there's ways for us to look, right? And then, sometimes other stuff like cancer. I mean, everybody's human, right? Just because you have lupus doesn't mean you don't get other things that happen to other people too. So we have to kind of just keep our minds open if there's anything else going on, especially if you're feeling poorly and it just doesn't get better, no matter what we're doing, right? So these are the things like that we're checking for when we ask you to go get blood work when you're not feeling well. And then I've hinted a few times about how much we don't love to give steroids if we can help it. So there have been lots of studies now that have looked at the things that cause damage to patients over time. And certainly if your disease is active, it's causing damage on its own, right? So if you've got active disease and we look at all the things that contribute to damage, steroids can cause damage, and side effects of steroids are real, right? They cause cataracts, bone loss, weight gain, diabetes, there's all sorts of things. But if you're really sick and active, we might need to use them because they're the Band-Aid, right? They're the first thing that's going to help us shut stuff off. However, this was a study where they looked at patients who did not have any lab changes associated with lupus. So they might have not been feeling great, but their labs looked normal. And if you take those patients who don't have lab evidence of lupus activity and you look at the number one thing that's associated with damage in these patients, and that can be anything, bone loss, cataracts, hair loss, skin disease. There's like a whole thing on this damage list of ways that lupus can affect people. The number one thing that causes damage in people when they don't have blood changes of active lupus is steroids. What this tells us is that we're using steroids way too much because people blame the lupus first line and say, oh, you must need some steroids. And it really tells us that if we can help it, we really shouldn't be using steroids unless we have evidence that inflammation is driving the problem. And certainly pain can come from other things related to the lupus, wear and tear in the joints, past damage of joints from the steroids, which it can do. And then, pain sensitivity and all these other things that happen. But we shouldn't be using steroids to treat the aspects that we don't see lupus-related inflammation for, because that's what harms our patients over time. So food for thought. And then self-care, I think, is so important when patients flare. So I won't take a survey, but if you don't have FMLA on file for your job, you should get it. Because if you needed to take time off for a flare, lupus flares are a legit reason to take a day off work, right? So get FMLA so that it doesn't impact your performance reviews and everything else. So I write a lot of forms for patients. So make sure that you talk to your providers if you don't have FMLA on file. And then, as you were talking about earlier, like community support, family support, if you're not feeling well, you need somebody to help watch your kids, cook you dinner, whoever that is, whatever your community is, really try to engage and build a community that can help you when you need a day to just stay in bed. And then all the other things that help us get over lupus, right? Anything that's going to help our stress level is going to be good for lupus. So sleep, important. Exercise is a great way to reduce our stress levels. And not everybody can go out and run 5 miles, right? But do some stretches. I think these programs that, we're offering here, they're great opportunities to sort of learn how to do these things in a safe way with your lupus. And if you have limitations, how do you work around them to make sure that you can exercise and stretch and use these things that are known to help the stress levels actually work for you. And then healthy food, I think, is also important. Now, granted, it's not easy to get access to healthy food, but as much as possible, like try to cook for yourself, try to eat your vegetables. If you have a choice between, a big greasy McDonald's hamburger or McDonald's salad, choose the salad. There's ways that we can tweak our diet to just over time make it less likely to trigger our lupus. And I think this was super important. I think such a good message, right? You have to trust yourself. We have lots of knowledge, but we don't know you from the inside. And so you have to advocate for yourself with your care teams. You have to know when it's time to take a break. And this can be really hard if you're a go-getter and you're like, I'm fine, I'm fine, I'm fine. It's a learning process to learn how to give yourself some grace and take a break when your lupus is just not where it needs to be. I always like to talk about common sense food rules because diet is important. Try to maintain a healthy weight, always easier said than done, 100%, but it's always a goal. But some of the tricks, eating foods rich in omega-3s can be really helpful. So wild caught fish, farmed fish don't have as many omega-3s in them because they feed them corn and soybeans. So they're not eating their normal fishy food. Grass-fed meat typically has higher omega-3s. Walnuts is a good source, actually. So if you like walnuts, that's a good one. Flaxseed, and you can actually, I just learned this, you can use flaxseed to substitute for eggs. So if you don't have access to high quality eggs, you can use flaxseed instead when you're cooking. That's a good trick. And then fish oil supplements. You just want to make sure they're from wild caught fish so that you get the omega-3s. And then again, if there's one thing you can do, I think avoiding high sugar and processed foods is probably the biggest impact. There's so many chemicals that are in processed foods, and we now know that they can break down the gut barrier and let that immune system crosstalk with the microbiome. And so if you can avoid these, I can't tell you how many patients have told me they've gone off sugar and they feel so much better. It really matters. And then there's this Michael Pollan's grandmother's rule. So I think it's a great one. If your grandma can't tell you what an ingredient is on a package, don't eat it. So I think that's a great rule, right? Simple, right? If you can't, I mean, I don't know if you guys saw Donald Trump's Tylenol press conference, but if you can't pronounce it, don't eat it. And then, yeah, so chemicals are important. And then there isn't any data to avoid tomatoes, by the way, but if they bother you, don't eat them. But you don't have to avoid tomatoes just because you have lupus. That's in a lot of lupus diets, but there's no data. Anyway, okay, I'm almost out of time. So again, if we find that your labs are off in your lupus flare, we go back and we treat what's active. So you already saw the listed drugs, and it's sort of looking to say, is what you're currently on, is it working? Should we stop it? Should we add on a different medication? And then do you need short-term steroids? Do you have enough inflammation that it's worth the downsides of taking steroids, right? So this is always a discussion. There's no hard and fast rule. It's about what you want. It's about what the doctor wants. It's about what we're trying to accomplish with the lupus. And I think it's always, is it worth the risk of steroids? Because they're not safe, right? They have consequences. And then we choose new medications based on the organs involved. All right, and then after we change your therapy, again, we need to keep an eye on you, right? Is the lupus behaving? Are we achieving what we wanted with the meds? Are the side effects from the medications more than what we bargained for? Are you tolerating it? Is it okay? And then get you off of steroids. If we had to use them, we need to get you off. Like the goal is never to leave you on. And then again, we want to think about prevention of future flares, like stop that light switch from being flipped. Sunscreen, 100%. Everyone should wear sunscreen 24/7, 365. You get UV exposure from fluorescent lighting, from the sun outside, even in Michigan. And then self-care, as we talked about, take your meds. If you're not tolerating them, let us know. I can't, we check levels of Plaquenil now because it helps us know about eye toxicity, but I've been surprised. Even my patients who are doctors, their Plaquenil levels come back at 0. So I'm like, if you're not taking it, just let me know so I can help you figure out what to do, right? But it surprises me how many times people aren't actually taking their meds. And again, it's not the patient's fault. It's sometimes insurance costs, like there's lots of barriers sometimes. But yeah, let us know so we can help you. And then keep your follow-ups. And then, Plaquenil really has proven track record for preventing flares. So there's tons of data. If people stop it, they're at a higher risk of flare. Belimumab also has some data long-term that patients flare less if they're on it. So again, these are things that have been shown to prevent flares, and other ones, there's studies going on. We don't know about Safnello so much yet, but they're studying that too. And so taking your meds can be important. And then I'm sorry I went over time, but just to show you I practice what I preach, this is my garden. So I try really hard to eat healthy diet. Yeah, I mean, you can grow your own food too. So you just need a little piece of dirt. But anyway, I'm happy to take questions, and thanks for inviting me.
Okay to eat tomato or no?
So yeah, so there's no data that tomatoes are actually bad for lupus. Now, if you eat tomatoes and you feel bad or you have an allergic reaction to them or something, but there's never been a study to show that nightshades actually, there it goes. The nightshades actually have any negative impact on lupus. I think all of that came because there are some nightshade family members that are weeds that grow in your flower beds that are poison, right? So black nightshade. And I think people just assume, like they make assumptions, like it's related to a family member, so it must be bad. You can watch influencers online and they're like, don't eat cashews because they're from the poison ivy family. I'm like, so it's the same logic, and think how nightshade's got a bad name now. full caveat, I grow a lot of tomatoes, so, you know, so yeah, there's no data, but if you eat a tomato and you're like, you know, tomatoes just don't sit well with me, then don't eat them. I mean, some people can be allergic to various things, right? So you always got to know your own body. But I don't think it's a hard and fast rule that you have to avoid tomatoes and peppers if you have lupus. There's just no, I looked because I didn't want to grow things that were going to make people sick, right? I spent a long time digging through the literature, trying to find a study that would convince me that this was actually a real thing, but there's no data. Yeah. I mean, it'll cause reflux, right? Sometimes, but just go back here.
Hi, so my question is in regards to Benlysta. I've been on it for 5 years.
Yeah.
And I guess my question is when are you, within your professional opinion, are seeing patients coming back and saying, this is no longer working for me, my blood work is seronegative, but I'm having all these symptoms, which is typically pain and swelling, not necessarily kidney issues. So in your opinion, when are you starting to see patients with issues again?
Yeah, so this is always the tricky part, right? Because patients experience things that may not even be related to lupus, right? So we can have pain for different reasons. We can swell for different reasons. As we get older, we get a little high blood pressure. We start to retain fluid more easily. We become more salt sensitive. So without knowing your lupus and your history, I would say if I like was reading a case thing and I had to pick an answer to a question of somebody who's been on Benlysta, still having pain and swelling and doesn't have any serologic activity of their lupus. If you did have serologic activity before, I would say the Benlysta is doing its job to keep the immune system from generating autoreactive antibodies and fighting your tissues. The rest of your symptoms are probably not going to be treated by any med. It's going to be more thinking about blood pressure, exercise, sleep, stretching, stress reduction, diet, like all the other things that we can add in. And there's no lupus drug that fixes pain per se related to lupus, right? There might be other reasons for pain, like you need to look into, are there other things going on? Is your vitamin D okay? Is your thyroid off? Like there's lots of stuff that we need to like think about in the bigger picture, but I wouldn't say, you know, if you had active lupus and then you got Benlysta and it went away, it's doing its job and no drug will ever fix every problem. I mean, you're very lucky if that's the case. So I don't know if that answers your question, but it's hard to, without knowing everything about you, like to say more. Yeah. Do we do one more? Okay.
I just wanted to say thank you for your presentation and just wanted to point out the Lupus Warriors, one of the very most important parts in there was just you saying that you know, medications can cure everything. That is not the answer. It is really a lot about what we're eating and what's going on around in our lives, like the stress and things. And I love your garden there. We all can change our diets and making sure we're avoiding sugars and processed foods first and doing our very, very best to do that. I wish I did it sooner, but I think that's great. And I just want to thank you for that information.
Thank you. Yeah, and we're doing, Dr. Berkins and I, we've tried multiple times to get diet trials funded through our lupus program as well. And we're still working on trying to find ways to study this better so that we can find out like specific recommendations that we know are going to be evidence-based that are going to help patients. And then the other piece is like trying to figure out how to get food into food deserts, like getting healthy, unprocessed foods to our patients. Not every patient has access to whole foods or can afford whole foods, right? So how do we build those access trails too? I think it's just a really important thing for us to think about, not only just in the lupus level, but at the societal level and our support and care of each other, right? So I'm gonna start crying, right? Think about that too hard. Okay. Thank you.
Amazing. Can we give Dr. Kallenberg one more big round of applause? Thank you so much. I know Dr. Kallenberg mentioned some sunscreens, and I know we all need it. I just wanted to plug that the Publicly Engaged Research Corps does have mini sunscreen bottles available in the room next door, so definitely check that out. But next, we'll be taking a short break and reconvening at 11 o'clock for our next speaker. So until then, feel free to help yourself to some more refreshments in the lobby and check out the vendor tables next door. Thank you. May I have everyone's attention, please? We're going to go ahead and start the next presentation. Our next speaker is Dr. Jackie Madison. Dr. Madison is a clinical assistant professor in rheumatology in the Department of Internal Medicine, as well as pediatric rheumatology in the Department of Pediatrics. She cares for patients with all rheumatic diseases and is enthusiastic about helping patients fit their medical needs into a full life. Please welcome Dr. Jackie Madison.
Hi, thank you so much for having me. It's so great to see the Detroit lupus community here. I grew up about 20 minutes away and my mom is a school teacher in the Detroit public school system. So it's really awesome to kind of be introduced to the lupus community in Detroit. Mhm. Okay, so for my talk, I'm just going to breeze through some of the recent newer medications and then talk to you a little bit about how clinical trials are done, why this matters, maybe give you a little preview as to what new trials might be going on, especially a little bit about cellular therapy, which is kind of one of the newest types of treatments on the block, and then give you a little advice about how you might think about whether a clinical trial might be right for you. All right. So it's an exciting time to be a lupus doctor because we're able to offer more and more to our patients. There are actually new medications in our list of options, which if you asked me 10 years ago, there weren't that many new items. Now I'm going to kind of tell you a little bit about that. So for about 50 years, we were kind of using the same medications, cyclophosphamide, mycophenolate. And for some patients, those work really well, super, but they don't work for everyone and they do cause problems. So in 2011, the FDA approved belimumab, Benlysta, which was the first new lupus drug in 50 years. So incredible. And then within a decade, its approval got expanded to lupus nephritis, which is really exciting. And mostly because this is the first medication that's specifically approved for lupus nephritis. Now, we know other drugs work for lupus nephritis, but getting this approval means it's easier to get it in your hands, both for like insurance purposes and also our confidence in knowing that it's safe and effective. And then in the last 5 years, we have a couple new items. So voclosporin got FDA approval for lupus nephritis, and then Safnello and afrolimab got approval for lupus. And then there's this other new medication, obinutuzumab, which has been studied in lupus nephritis, and it might be approved as early as next month, but we shall see. We're learning lots more about other aspects of care too. So there's new guidelines. There's from the American College of Rheumatology, and this matters because these guidelines go out to all rheumatologists. They're available to all doctors, and so people can understand and better appreciate all that's required for the care of our patients with lupus and lupus nephritis. We also appreciate that we can use less steroid than we thought we could, which is always a good thing. And then we're also understanding other aspects of impacts of things like health disparities, economic disparities on lupus outcomes. What other non-medication options can we give our patients? So how have we come this far and how do we go further? Research is really the answer. That's how we get proof that these ideas for new things actually work and are safe. So just really briefly, I've kind of talked about some of these new medications. And for example, belimumab, this large clinical trial showed that people's indicators of their kidney health are better when they're on belimumab. Voclosporin on this medication again, so there you get less protein in your urine, which we think is an overall marker of your kidney health. Those results are better when you take voclosporin in addition to your other medications. Anifrolumab, approved for systemic lupus. We know it's helpful for lots of aspects of lupus care. This graph is showing you the probability of flare. So like Dr. Kallenberg talked about, identifying lupus flares. It takes longer, you have less flares when you're on anifrolumab. And then this newest one, obinutuzumab, is another one of these names that's a real mouthful, but it is another drug that is used to treat specifically lupus and lupus nephritis, so kidney lupus. This is an immune suppressing medication. It's an infusion, and it lowers the amount of antibody producing B cells. So when we think about lupus as an autoimmune disease, we know that we have to address aspects of the immune system that are working against you. And so this medication reduces B cells. And so if we think back to, immunology or basic biology, B cells are one of the types of cells that produce antibodies. And we know that in lupus, you have these antibodies that are doing bad things and they're attacking your own body. And so this drug reduces those, and it seems to be an effective treatment in lupus nephritis. The problem though, so the top graph is showing you, okay, your kidneys, they end up better when you're on obinutuzumab, this new drug, but you also are at increased risk of infection when you're on this new drug. And so we're always trying to think of ways to balance risk and benefit of any drug. We think about this for an individual patient, but we also think about this for, the lupus community as a whole. And so depending on the patient, this might be a good choice for them, or it might not. And we're always thinking, what's the next best thing? What can we do? Lupus care overall, all of these new medications are being more and more targeted. So instead of a medication like cyclophosphamide that just sort of wipes out lots of different types of cells, these new medications, they try to target a molecule or a specific cell type. What can we do that is a more focused approach, and so we don't get as many side effects that are causing other problems? So I wanted to tell you a little bit about how clinical trials are done, and you may know more or less about this if you've been a part of one or thought about it. There's lots of types of clinical research. So there are some that are under the category of observational, which means you just sort of watch what happens and look for patterns. And so sometimes this is done by just looking at medical records. Sometimes this is done by also collecting some data from your blood or other types of tissues and trying to correlate, what's going on in your blood. Is that what's happening in the person in their clinical history too? Sometimes this involves filling out surveys or doing interviews. And sometimes it involves being a part of a registry. So sort of a list of patients that we can talk to if we have a new question. Then there's a whole other type of clinical research that's considered investigational. So you're investigating a particular treatment or, and treatment can be very broad. It can be something like acupressure, or it can be something like a new immune suppressing drug. If we do this in a really rigorous way, it is a clinical trial. Sometimes these are compared with a placebo, so like an inactive pill or drug. And sometimes they're not. Sometimes it's called open label, which means everyone gets the drug, and we're going to see what happens. In clinical trials, there are really strict rules about it, and there are these different phases or different steps you have to go through. Phase 1 means it's just given to a small group of patients, and they're looking to make sure it's safe. Phase 2 goes to a bigger group of patients. They're looking for safety, but also seeing the effects of the drug. How effective does this look like it's going to be? And then phase 3 is an even larger group, and it's really focused on that effectiveness, still taking lots of information about safety and looking very closely at that. But it's more looking at how this new treatment compares to current treatments. And if a drug shows that it's really effective in a phase 3 trial, that's where you can move to getting approval from the FDA, which means that this will be approved by things like insurance companies. It's well publicized to your doctors. And so it's really important to get through these different phases, make sure that something is safe, and also make sure it's effective enough to be worth any risks associated with. There is a fourth step, phase 4, and that looks at risks and benefits in much more widespread use. Make sense, kind of? Yeah, okay. Safety. So I mentioned, in all of these steps, safety is kind of the prime target. And a drug, no matter if it, works and treats the disease, if it's not safe, it's not worth it. So it's really the primary goal in any phase of these trials. Whenever you're in a trial, you come in for different visits, and the doctor or investigators will look at different things as what's going on with you. And safety is basically the primary thing that they're looking at every one of these visits. It'll be the doctors who are, part of the trial monitoring for safety. There's also oversight from people within the trial. And then there's something called an IRB, which is a group at the institution or hospital that is not associated with the trial, but also looking out for your safety too. And you have to prove safety at every one of these steps and to all these different people. So what might happen if I decide a clinical trial might be right for me? So the first thing is screening, and this is really rigorous and strict. So you need to make sure that you're eligible for the trial. Depending on what phase it is, they might be looking at, how does this drug work in generalized lupus? How does it work in people with chronic pain, whether or not they have lupus? Maybe it's only looking at people with a certain type of organ involvement in their lupus. So maybe skin, maybe kidneys, maybe nerve involvement, anything. And so depending on the trial, even if you have lupus, you might not be eligible for a given lupus trial because they're trying to prove its effectiveness or safety in a particular group of patients. And sometimes when you're doing an investigation into a new treatment, you might start small, start narrow, and then broaden, or they might start more broad and say, oh, okay, in the phase 1 study, it seems to work really well for people with lupus of their kidneys, but maybe not as well for people with the lupus of their skin. So it could go either direction. And then also in this screening process, to make sure that you may or may not be a good fit for a trial, they may talk to you about, you might have to change your current treatment. So for example, if someone's on a really high dose of prednisone, you won't know if it's the new treatment or if it's the prednisone that's treating symptoms or whatever outcome is being assessed. And so they might have to work with you on, decreasing your prednisone dose before starting a trial, for example, but there's a lot of different things like this to consider. The next step, if you get through the screening process and says, yes, you would be a great candidate for this trial. The next step is more on you, so your consent. And so the investigators would go through, what's going to happen to you in this trial? What do they expect? What are the risks? What are the benefits? And if you decide that you want to proceed, you would give consent. And so that would involve talking with one of the investigators in a lot of detail about what's going to be happening. After that, boom, you're enrolled, you're in the trial. And that usually involves an initial visit where they may or may not take blood or have you do surveys or just kind of get a baseline of what's going on with you at the beginning. And then there would be follow-up visits to assess and see how things are going. And even after the trial, so maybe a trial runs for a year, for example, there might be follow-up after that to say, okay, so you were on this treatment for a year. What happened after that? Is this something that's long lasting? Is this something that's not? We need to figure that out. One thing I want to, highlight, especially for you guys, is that participation is always voluntary. If something is not right for you, you can say no, thank you. You can usually stop at any point, with the caveat that you should probably only participate if you think it's something doable for you. But you can always stop and say, no, I don't want to be a part of this anymore. You do have the power there. And the other thing is you should always ask about compensation ahead of time, because you are the one, giving to science, giving to knowledge, but also things like extra trial visits, they take your time, and they might also take things like your travel to a certain doctor's office or location. And so you should be compensated for things like, gas money or whatever it is that you're giving to be involved. What are the challenges to clinical trials in lupus? Why did we not have any new drugs for 50 years? What's going on there? So there are some challenges. As you guys are probably aware, especially as you talk to one another, lupus is a very diverse disease. It affects people really differently. This is, biological. Certain parts of the immune system are turned on more in some patients versus another. Certain organs are more involved in one patient versus another. There might be more skin involvement. There might be kidneys. Some people have more chronic pain than others. We don't totally understand why in all cases. So that's a challenge, making sure that we have a treatment that affects, a particular area of interest. Is it broad enough to affect lots of parts of lupus? Is it only specific to one part of lupus? It's really challenging. Another challenge is that oftentimes this isn't true for every type of treatment assessment. Trials are often done at large academic centers, and not everyone lives close to a large academic center. That's a challenge. There's not always a lot out there in terms of what knowledge is getting to patients. I think this is changing a little bit with social media and awesome things like the Detroit Lupus community and different patient networks, but it's not always publicized super duper well. Patients have busy lives. You are busy doing other things. You might not have time for extra trial visits or traveling to an academic center. Also, doctors are pretty busy treating patients, and not every doctor has time to take on a clinical trial in addition to all the things that they're already doing. And trials take a lot of resources to run, which makes it difficult. But we know that it's really important. And there's a lot of potential benefits to clinical trial participation, both from helping the larger community, but also individually, there might be some benefits. You'll have to think about if that's right for you. You would get access to new treatment before it's widely available. Like I mentioned, you should get compensation, close care. For some folks, seeing their rheumatologist more than every 6 or 12 months is hard. It's hard to get in to those slots. And if you're in a trial, it might be that you're seeing once a month, every 3 months, could be more than you're used to. And then sometimes even when the trial is over, there's an extension study. So you get to stay on this medication for longer, especially if it's been helpful to you. And the other thing to think about is, it's not just your own lupus care, you might be helping others in the future, although that's a little more vague and no guarantees there. Okay, so what new trials are going on? Tons. There's lots of new medication trials in lupus, which is amazing. That wasn't necessarily the case 10, 20 years ago. And the new trials, it's a wide range. Maybe there's, a skin treatment, maybe there's a new injection, new infusion medicines, really wide variety of things going on. One thing I wanted to highlight, because it's getting publicized and it, shows a lot of promise, is something called cellular therapy. So I mentioned earlier that we think B cells, these immune cells that produce antibodies, they're part of the problem in lupus. We know that because there are lots of autoantibodies in patients with lupus, like double-stranded DNA. We know that a lot of these can cause damage to organs. But, what would happen if we eliminated these B cells? Can we do it more effectively than some of the medications? Is there another way to do this? Can the treatment last? So enter CAR T cell therapy. So some of you may have heard about this. I'm seeing a couple nods. In this type of therapy, it's very involved. You take a patient's own T cells, and then you engineer them to destroy these B cells, and then you give them back to the patient themselves. So starting up here is kind of how I would read this picture. So apheresis means you take out cells from a patient, you only save the ones that you want, and then you engineer them. So add these little receptors here that target B cells, and then you give them back to the patient. And then they go in and they destroy all these types of B cells. So what does that do for a lupus patient? As I mentioned, this is a really complicated process. After you take out the white blood cells, you have to wait 4 weeks until you get them back in your own body. And then, you lose all your body's B cells. Is that dangerous? But does it mean that you get this sustained remission from your disease? And the exciting thing is that it looks like for some patients, the answer is yes. Now, this is all very preliminary. This is not widely available. It's, I talked about those different phases of clinical trial. It's only been published in phase 1, although it's reached the second step, phase 2 in some places. And so I think more and more information will be coming out about this. And so you guys should know about it. So this was a publication about the first 5 patients. And this is looking at their SLEDAI score. So there's different scores for lupus. Anything above 6 or 8 is quite high. Like these patients, their scores were 16 and they went to 0 or 2. So this is incredible. When we look at things like how much protein is in their urine, within 3 months, it went to either undetectable or normal levels. Their complements went up the way they should. Their double-stranded DNA antibodies all went down. And then also patient-reported outcomes. So things that you guys care about more than a number. Fatigue decreased. So that's amazing. There's something else called CAR-NK cell therapy. So at that picture I showed you where they, take the T cells out of your body and then engineer them and give them back. In this therapy, and maybe some future CAR T cell therapies too, that first step isn't there. And instead, they have these cells ready to go and they can just skip to the part where they infuse them into patients. You often don't need as much monitoring, which is exciting. And could it be more safe and does it work as well as CAR T? Well, that's what's being studied now. It looks quite promising. We don't know yet, but these trials are underway. There is another form of new treatment coming out. I don't have time to tell you too much about it. Something called BiTEs or BiKEs is the abbreviation, but T cell engagers would be kind of the name of it. And that's another new exciting treatment. It also decreases B cells, maybe not as completely as the cellular therapy, but is that enough? Is that going to be what's going to work well for lupus patients? We don't know, but we're pretty excited about it. So we'll see. There are many more therapies in progress too. If you do a quick search at the NIH website of how many lupus trials are out there, over 250, and I double checked, and 22 are listed in Michigan. So that there are new things coming out. When you think about, is a trial right for you? I think the most important thing is to talk to your own rheumatologist so they can help you get a sense of, would I be eligible? Am I at a good enough place in my lupus where I should try looking at a clinical trial and what type? The FDA has a patient website about patients interested in clinical trials, and they came up with this list of questions that you should ask before joining a clinical trial. And just because I'm running out of time here, how do you get involved in clinical research? You can check some websites like clinicaltrials.gov. That gives you that big search that I showed, but also things like lupustherapeutics.org will point you the right direction. Again, I just showed you that one. This is the Lupus Therapeutics website. We at U of M are running some trials. We have one CAR-NK, so one of those cellular therapy trials open for lupus nephritis patients. It's limited to that right now, but we'll see what happens in the future. And then we also have another lupus nephritis medication trial that's coming up, and we're hoping to offer more for systemic lupus that doesn't just involve the kidneys. So if you're interested, you can contact one of our coordinators and we can be in touch. All right, I think we have time for Q&A. Actually, I'm not running the Q. I'll let you run the Q&A.
Yes, thank you. Could you speak briefly about the chemotherapy involved in the?
Yes, in the cellular therapy trials. Yeah, I'm going to go back to that picture because I think it's helpful. It's a little busy, but I think it's mostly helpful. Maybe do this side. So other things that are involved. So you stop your current medications because one of the outcomes they're looking at is patients who have gone through these and done well, they're not on any other lupus treatments. Some of those patients were first treated about 3 years ago, and they're still not on any of their previous lupus treatments. They're not on steroids, they're not on immune suppressing medicines, they're not even on Plaquenil, which is amazing and incredible. But yeah, so you alluded to, this is an involved process. So you get these cells taken out, but before you get new cells put in, we need to make sure that your body doesn't react to those new cells and destroy them immediately. And so you do have to get essentially chemotherapy. And so it involves 3 days of chemotherapy. The medications it's a little different per trial, but usually it's something called fludarabine, which is used a lot in patients with lymphoma and leukemia. So you get 3 days in a row of fludarabine and 1 day of cyclophosphamide. So that's a medicine we're more well versed in with lupus, because some lupus nephritis patients and other types of lupus have received that kind of medication. And so you would get IV infusions of these chemotherapy drugs, and then that's it.
Yeah, so at U of M, are you doing CAR T cell?
We are we're doing CAR NK cell therapy. Yeah. Hmm. So far, we'll see. Yeah. Yeah.
Once so they then consider being genetically modified organs.
No, because it's not affecting their own genes. It's just infusing the cells. And the other thing is the cells get in there, they work, and then they go away. So within 3 months, for most patients, those cells are totally gone.
Is there a reversal?
Your own B cells come back, and this is the extra amazing part. Your B cells come back, but they're not autoimmune reactive B cells. When you look really closely at them molecularly, they look like healthy B cells that have never had any autoimmune type of properties. Crazy, right? Yeah.
So are you immunosuppressed after this is done, or is your immune system like back to normal before you had lupus and you don't have increased infection risk, et cetera?
It looks like it comes back. So when you get the initial chemotherapy, yes, there's definitely some risk of infection, but it's not super long lasting, which is wild. And what we've also done is look at, I have not personally done this, but as a research community, they've looked at, okay, so we're wiping out all these patients' B cells. We kind of depend on B cells. They have good functions too. So they looked at their vaccine titers, and people still have had responses to vaccines that they've received previously. And also a lot of these trials were done during the COVID epidemic, and they still had response to the new COVID vaccines that they received. So a lot of promise, still early. You would need to think about whether it would be right for you to participate in something like this. You'd still be pretty brave.
Thank you, Dr. Madison. Can we all give her another round of applause? Our next speaker is Ms. Christina Hayes. Christina is based in Detroit, Michigan, and works as an organizer for Mothering Justice, a grassroots policy advocacy organization that provides mothers of color in America with resources and tools to use their power to make equitable changes in policy. Please welcome Christina Hayes.
Hello, everyone. My name is Christina Hayes, and I am here to share a little bit about my story. Being a lupus warrior myself, I was diagnosed with lupus when I was 19. I'm now 38, I'm almost 40. But I like to tell people, I share my story, not to traumatize anyone that's diagnosed with lupus, but more to inspire you to take the avenues to heal yourself and to help with feeling better and doing hopefully more naturalistic things like eating better and removing different stressors out of your life to make yourself feel better. I've been hospitalized over 100 times with different things, different issues pertaining to lupus. So if anyone ever has any questions or if you ever need any support, I've been a support group leader as well. I'm always able to be here for Lupus Warriors. When it comes to lupus flares, I haven't had, when it comes to lupus flares, while I was in the hospital a good 100 times, I've never had to have like an extreme type of surgery or anything. It was more like issues with arthritis pain, extreme pains, and needing medications to support me while I'm going through a flare. But 2.5 years ago, I had to have major life-saving surgery. I ended up with a blood clot that came in my stomach, and it cut off oxygen to my vital stomach organs, like my intestines, my gallbladder, and my colon, all had to be removed. So now I have what is called short bowel, and I'm also a custody patient, meaning that a piece of my intestines lives on the outside of my body. And I also have what's called a Mickey button, where I do tube feeds to supply my body with nutrition. I know that sounds like a lot, but this documentary me and my family decided to make was just around my 6 month stay that I had to do in the ICU recovery. I'm a person that says lupus will never get me down, no matter how many flares, no matter how many times I've been through something. Lupus 0B115. So me and my family decided to make a documentary. It was to be entered into a contest about caregivers and why caregivers matter and are so important. And as Lupus Warriors, we know it's important to have people in our lives to help us in this fight. My mother is here, and she's also going to be in this video and also in the panel today, so you'll be able to ask her questions. But feel free to watch the documentary, and after, if anyone has questions, feel free to ask. Yeah, just feel like you're on I'm an intentional James. I am Christian Hayes' mother. I'm also a paladin and also an author of the Bachelor's Story and Memorial Pen Myself Publishing. I'm here today to share a story after the stand up. I'm also here for my husband, and then I'm adopted into my uncle's children, and also here for my mom. So then, so do to be in our last week. So you don't have to do that. You don't have and we're gonna get in church. I'm gonna do something maybe. We can share a little bit about my story and why your person matter. My wife's reported to necessity of a life. I'll guide you to the tissue disease at the age of 19, and then at 2007, the caregiver was 23. I was a sophomore at university, and what was funny is strange. I was slowly getting more fatigued every day, more tired every day. I just couldn't do the normal things that I like to do. I started missing class, I was oversleeping, I'm not having fear now. I feel like it's wrong because I need to leave it too much. For the team, she's like, oh, you have this, or we have this medication for relieving that. Take the other medication for relieving that. That was really little me, like me, every time that I ever want to. I think I teachers because this is so much important. This is all my mind. And then I got to a point where I couldn't even carry a car and survive. That's when I knew that I was going to he's the most special to the figure out like wrong and figure it out, figure it out. My whole sense of the whole and the feeling is cool. I didn't know what was wrong. So like I right up street at our University of Michigan Hospital. After call me and just said, comments of what you're bringing along with you. So I was my mom that day, and the doctor said, Something things in your lab, where what you're not. And this shoot this is all about. And she was like, no, you're. Coming from the middle here, and just know that I want a journey. And we look at this, you're gonna see a lot of bicycles and down. For me, I was young and then walk by that farm, like, okay, so look at that was cool, now, that's one of the things that great. Searching for order groups and things like that. The knowing wrong way, where about maybe with that. Things like that. If it was not happening, that, you know, I don't know let these independently or take over, you know, I was so happy to find out trying to do this that I'm able to get one of my training job. Do where we got another one here. And it's like, well, it's done, and I'm like, wow. I got it. All right. You were and that bring flowers, guitar, and everything like that. show that they're going to sit there and listen to them, make a little plan, you know, you know, they will be about resources that about, you know, a person more than when they get around the good, like, babies, girls, really, all that feedback, feedback, I go very is you're creating, really security, this is for 2 weeks. Well, and once they did that, I was there, that being done, I was trying to work even how we think of, but you're trying to work even everything you do, like being concerned. Making the first one, like, make up with all your head in, you make it right, right. We was thinking that was here. So this is how the surgery was live here, recording here, whatever you want to say, and I'll make sure that it's your name. And yeah, and I'm going to count on shootings, one day, so why change for being trapped? I have to walk and I have to surgery for 6 months recovering. I learned about problems and journey. You know, have to do a job. Take time off work, good job. I'm being yes. Change or you pay for after the 11. So board specials with the gift of life, as you know, which is organ procurement. So I have people tissue donation. And what I realized in all of my profession and all of my assignments and how can kind of tie into Christina's journey, the Christina's project is that it's not about finding crime, it's not about finding out who did it, it's about the life. And all of those things to my Christina's profession and as a career caregiver that I am and realize it's those moments, it's those memories, it's those opportunities that when you experience as a clinician, as a seen her absolutely nothing to work, she's just like, I don't even get the time to be with those ones that I admire that I was chosen as an ambassador to not only be for our land, but our families be for others. It's definitely spiritual journey for me, watching her do these 17 years of enduring this real of these amazing. And in addition to things, I've seen her struggles, I've seen her cry, I've seen her in pain, I've seen her where she was crippled, she had nothing to walk around. And I have seen her even put her side including or vision. And witness as a caregiver, in this last episode that she had, they chose that she would discharge of nursing home because of her resignation and true sleeping routine TV in. And I like nursing home. No, he's not going to me. So parents bring my minister that and was thinking how being able to my work and behind that and what I have seen when we get the fight is be able to be a workers and standing out and providing your works and function a lot of years of creation, like I said, or I haven't been back to work, I haven't been to months. And really, I see one capacity to see present, one department I'm organizing in, I don't take their the later one knowledge, you know, like how I'm a board and also programming about individual the strength to one I person and it's so much it's an honor to be here for your whole mother. To just be around the journey to be almost she's living with me. God, to make tell us about that. To be able to support and to share love and to be a witness. Just and then everyone has been under those. And in their journey, we invite audiences to reflect on the universal themes of life, time, and the immeasurable value of caring for one another.
Thank you all so much. I don't think I can hear everybody, actually. Can we give another round of applause? We have a few minutes for some extra questions for Miss Christina at this time.
Yeah, so that was my story. We all like the documentary there. Do we have any questions? Any questions? No, I know that was a lot to take in. Thank you, thank you. Y'all can make me cry. I got a little emotional watching it. Every time I watch it, I get a little emotional. But I'll definitely say my good days outweigh my bad all the time. I am still a paid leave organizer because I know what it's like to take time off. And just this year, we won earned paid sick time legislation, which is a law that allowed you to you earn 1 hour of paid sick time for every 30 hours that you work. And that was a major win for us this year. And we're still currently working on paid family leave, which means you'll get up to 15 weeks of time off. I work with State Senator Geis on making sure that that happens. And my lovely coworker Tanisha is here back there, and she's manning our table. So if you ever want to learn how to effectively share your story, I also lead our speakers bureau because I've had a lot of speakers training on how to effectively share my story on the need for taking time off and also the need for caregivers taking the time off of work. And we all know that it's FMLA out there, but FMLA, you have to exhaust all of your vacation time and PTO. And then after that, you go unpaid and you're drowning in bills. So I know about that experience as well. And I'm here if you want to learn how to share your story, I can help you do that as well. And just feel free to take my information and I'm here to be support for you all. And I'm very grateful to be here and it's a blessing to be amongst you all.
Thank you so much, Christina. I don't think there's a dry eye in the house. Next, we'll be taking a break for lunch and reconvening at 12:30 for our next presentation. Lunch is located in the lobby, the same place as breakfast. And if you haven't already, we have a memorial wall activity in the back corner of the room to honor anyone who wasn't able to join us today for any reason. So definitely check that out. Thank you.
At least 6 up front, at least 6 here.
Our next speaker is Dr. Drew Sturgeon. Dr. Sturgeon is a fellowship-trained licensed clinical psychologist and clinical assistant professor in anesthesiology at the University of Michigan School of Medicine. His research involves individual resilience in chronic pain, as well as brief telehealth-based visits. Please welcome Dr. Drew Sturgeon.
Hi, everybody. Can you hear me? All right. I'm Drew Sturgeon. I'm a pain psychologist at the University of Michigan. I've been here for about 3 years, but I'm actually from Michigan originally, so it's nice to come home and see what I'm doing. So I'm going to talk to you all today about chronic pain in lupus. So we'll start here with some information that's probably familiar to most or all of you. So bear with me if you're hearing some stuff you've heard before, but we're going to try to get into maybe how pain is a little more complex than you might be told sometimes by medical providers. So at a high level, when we think about lupus, what we think is happening that might be causing pain is that there is chronic, ongoing, usually especially when poorly controlled, inflammation can cause damage to tissues, to joints, to organs. And that's usually the primary treatment goal of lupus, is to try and get that inflammation under control so that we can protect the body, right? So pain is actually one of the first symptoms many people with lupus have that kind of lets them know they have the condition. And the most common form of that is usually some form of musculoskeletal pain. So back pain or joint pain. But there are also a lot of people who experience headaches or abdominal pain. And so when we think about the active thing that's happening in lupus, we want to make sure that we're protecting the body by getting this inflammation under control. That's why you get things like medications that reduce inflammation or those that suppress immune function overall, as well as some of the things your doctors might ask you to do, like make sure you get protection from the sun, change your diet, work on sleep, work on hydration, stop smoking if that's an issue for you. So all this is pretty familiar thus far, right? So there is a common assumption. Thank you, Tiffany. So I don't get neck pain, right? So there's a common assumption that the amount of pain you might feel from lupus is related to how much inflammation you're having in your body or the amount of damage that the body has maybe sustained because of the condition. But it turns out it's a lot more complicated than that. And a lot of this work has come out in the last 5 years or so. A lot of it done by a rheumatologist at Stanford named Lola Falasino. So some of her information, I don't know if you can see this in the back, but some of the information on the right is from her research group. And so what they found is that among people with lupus, about half of them also have some other form of ongoing chronic pain. So chronic back pain or chronic headaches, and about between 15 and 30% of them have what's called fibromyalgia. Y'all heard of fibromyalgia? So there's actually a nice slide in the back that's kind of talking about different forms of pain. Fibromyalgia is a form of chronic pain that we call nociplastic, meaning that the primary cause of it is actually alterations in the brain and the nervous system. Your body can be totally safe. You can be completely disease-free and have severe, even disabling pain if you have fibromyalgia. And in people with lupus, maybe up to about a third of them also have fibromyalgia. So it turns out when they start to do systematic research on this, that the relationship between disease activity in lupus and pain is actually not as strong as you might expect. So only about a third of the total amount of pain that we can predict actually is associated with the amount of damage that we see from disease activity or current levels of inflammation. All right, so that doesn't mean it's not important. It obviously is. We want to keep the body safe. But as we think about pain, there's a lot more going on, especially if your pain is chronic. And when I say chronic, what I mean is pain that lasts longer than 3 months. So you all heard these terms, acute and chronic pain. I know this can be messy, especially if you have a chronic condition, right? So when we talk about acute pain is useful. It lets us know when the body is sick or damaged in some way. It promotes healing, right? If I break my ankle or burn my hand on a stove, it lets me know, protect that body part, let it heal, let it recover, right? So we need that. So people that are born without the ability to feel pain don't tend to live past childhood because they can't tell when something's wrong with the body. But if pain gets to this point where it lasts longer than 3 months, that we call it chronic. And there's 2 reasons why this is important. The first is, if I have a new injury, if I throw my back out or break my ankle, I should leave that alone and let it heal. But if after 3 months of leaving it alone and letting it heal, the pain is still there, continuing to avoid using it probably won't help it anymore. It actually might make it worse. So at that point, if I've been avoiding using my back or my knees or my neck or my shoulders, they might actually get weaker. And over time, the body might be less able to handle anything that you're asking it to do. So the other thing that's important to know is if you have forms of chronic pain, there is usually no one treatment that makes pain reliably go down. So this is true for medications, it's true for surgeries, it's true for forms like exercise. No single thing makes chronic pain go away. And that part of that reason is, if we think about what's really happening, it's often not just trying to get the body into better shape. It might be that something else is happening too. So at a high level, the way pain works in the acute case is if I put my hand on a hot stove, there will be nerves that detect that there's tissue damage. It's transmitted from that site of injury through my spinal cord and into my brain, right? My brain will register that something's gone wrong. It'll send a signal back. It'll tell me to pull my hand away so that I don't keep damaging it. That's acute pain, right? But it turns out pain is more than just that sensory feeling. All pain, regardless of whether it's acute or chronic, regardless of the person, always involves cognitive, emotional, and social components. Meaning that when I feel pain, it's not just, does it feel like I burned my hand or broke a bone? It also is hardwired with like an emotional response, that I might be afraid of the thing that hurt me. It might teach me to avoid the thing that hurt me. And again, if I'm a kid and I put my hand on a hot stove, that's really useful. But if every time I exercise, my pain goes 10 out of 10, that might not be as useful for me to know. And what we've kind of learned, so the social piece might actually look a little bit provocative to some of you. This is actually from the largest pain research group in the world, the IASP, the International Association for the Study of Pain. Social components of pain, which means anything like social support that might reduce pain, but also social things like not having housing. All of those things actually contribute to how much pain somebody has, right? So it's more than just what's happening in the body, it's also what's happening in the environment, okay? Now, the other thing that's important to know, when pain goes from acute to chronic, there's also evidence that your brain and your nervous system change. So if you've had pain, something's been going on in your body and it keeps sending that signal to your brain over and over and over again. What happens is, if you have acute pain, the parts of your brain that are active are related to sensation and attention. You need to know that you damaged something, you need to know to protect it. Makes sense, right? If you have chronic pain, in addition to those areas, it also involves brain circuits related to learning, memory, and emotion, which means when your brain sends a pain signal in chronic pain, it's not just about what your nerves are saying about your body right now. It might be that the brain has already learned to overprotect your body based on the stuff that's already happened. Does that make sense? It's a really important point. It's important to know chronic pain is just as real as acute pain is. But what can happen is the brain loses the thread. It starts sending pain signals, even at times that the body might not actually be in any immediate danger. So I got ahead of myself and explained most of this already, but the idea with chronic pain in the brain is that your brain learns to protect you based on what's already happened, but sometimes it learns to overprotect you. And that's why across pain conditions, by the way, so not specific to lupus, this is true for chronic back pain. It's true for conditions like multiple sclerosis, even true for conditions like spinal cord and cancer. There's actually not that strong of a relationship between how much disease activity we see or how much damage we see on an X-ray and MRI and how much pain somebody has. Again, that's not to say that the health of the body isn't important. It is. But my analogy here is looking at somebody's scans and trying to predict how much pain they're in is like looking at a bag of flour and knowing how the cake's going to taste. It's an important piece, right? But it's not the only piece. And as somebody pointed out to me, you can actually bake a cake without flour. So there are forms of pain that don't involve body damage at all. So the important thing to know is as we're trying to think about pain management in a condition like lupus, obviously the first thing that needs to happen is we are trying to stop that inflammation. We're trying to protect the body. But even in some cases, if the medications work, if the management plan works and pain continues, part of the reason might be that your brain and your nervous system have learned that you're in danger and they don't know how to shut that off. I promise I didn't pay that person to ask that question. We are going to get to that. Thank you for asking that. We are going to talk about that in the latter half of the presentation because that is exactly what we want to do. That was perfect. Thank you. So I like to also use the analogy here that pain is like a microphone. The brain's like a microphone, right? So if I put my hand on a hot stove, that's the brain correctly telling me, don't do that. You're going to damage yourself, right? But anybody here ever been on a Zoom call where somebody's mic is way too sensitive? You can not only hear them talking, but you can hear them breathing. You can hear the dog walking in the background. All that stuff is real, right? That stuff is happening, but it's not what the mic's supposed to pick up, right? It's sending a signal that we don't actually want. That's what the brain does too. So it might be that, for example, there's a structural problem in the body that's pretty mild, that the body's handling pretty well, but the brain can actually start to turn that volume up and send pain, even though nothing is immediately dangerous about it. Does that make sense? Still a real signal, just not telling you anything useful, right? So I mentioned this earlier. This is one of our oldest models in chronic pain. The idea is when I have a new pain condition, something starts, my back starts to hurt, my knees start to hurt, my head starts to hurt. I might start to avoid some of those things that immediately make pain worse. But in doing so, I might actually make my life harder. I might stop exercising. I might stop socializing. I might stop sleeping. I might start drinking more. And the problem is when I start to go into these extreme patterns of avoidance, my body might actually get worse. If I stop exercising, I might get deconditioned. And now the next time I try and move, it will hurt more. So this is a problem that can feed itself, right? This model, by the way, is about 40 years old. This is not new information, right? So if you ever wondered why, if you've gone to a doctor and asked about pain treatment, one of the things they're supposed to recommend is physical therapy. It's true for basically every form of chronic pain, right? Because even if you've been managing the condition well, your body still needs to move, right? It's not, physical movement is not the only piece that's important, but it is important to know this is true for lupus. It's true for every other chronic pain condition as well. So when we think about managing chronic pain, in addition to those medications or the interventions you use to stabilize disease activity, that you're trying to get that inflammation to go down, we're also trying to keep the body healthy and the brain healthy. So that might mean working on medical treatments, but also working on things like physical therapy or exercise and things that affect the nervous system. So that question was asked earlier, well, how do you get the brain to stop overprotecting you, right? We have specific treatments for this, right? And one of the immediate things things here is stress, right? Pain produces stress. I don't have to tell anybody in this room that. The problem is stress can also feed back in and freak the brain out so that you end up with more pain. So one of the things we want to do is interrupt the experience, the connection between stress and pain. Easier said than done, right? That's why I have a job. But I do want to make this point here at the bottom really important. Going to see somebody for physical therapy or seeing a therapist to work on stress management, it's not supposed to replace your medical care. The research across conditions has been very clear on this for decades. It works when you do it all together. Okay. None of this is meant to replace getting good medical care that helps manage your condition. Smaller than I expected it to be. So specific to lupus, when we talk about exercise, there's a lot of things that people with the condition understandably are concerned about. It turns out, if we look at large scale research, physical activity does not actually seem to worsen disease activity. So if you exercise more, it's not likely to worsen your inflammation in a regular, ongoing way. In fact, there's even some new research, this paper on the right, I had to look up what an interferon signature was, but as of a few years ago, there's even some evidence that exercise might help reduce inflammation if done regularly. But the other things that we know it does, it protects the cardiovascular system, it improves your mood, it improves your sleep, it can help the body be stronger so that you can do anything else that you want to be doing. There's also some research, not a ton, on psychological or behavioral treatments. So one of the most common forms of treatment is called CBT, cognitive behavioral therapy. You ever heard that term before? So there's a form of this for basically everything. You know, there's one for pain, there's one for insomnia, there's one for depression, there's one for anxiety, one for high blood pressure. You can use it for weight loss. It's seriously, there's a form for everything. But what it is it's a toolbox. It gives you a set of different techniques you can use to either reduce stress, to work on things like sleep or mood. It helps you manage things like difficult thoughts that might come up when you're in the midst of a pain flare. And so with every person, you give them a set of tools and people then learn how to apply it in their lives. And some people need some of the techniques and not others, but it works to some degree in basically every pain condition that exists. The other is mindfulness meditation. And that, as I said earlier, one of the key ideas in chronic pain is we want to interrupt the relationship between pain and stress. Meditation, especially forms of meditation like mindfulness, are meant to do that. Where what you're doing is not clearing your mind or distracting yourself. You're learning that when pain is there, you can actually slow down that stress response and learn to be calm or neutral, even as pain shows up, so that you stop feeding that circuit. Okay. I want to be clear. A lot of the research, there's not that many trials of this in conditions like lupus. Okay. A lot of what we know about chronic pain comes from other conditions that get studied more. And so there is definitely a need to do more of this work. I do want to talk to you all about something that's made my life a lot easier in the last 3 years. So there's a clinical trial that was published in 2022 on a therapy called pain reprocessing therapy. They even had a documentary about it. So this was in Boulder, Colorado. It was people with chronic low back pain. And what was remarkable about this study is that, so it was a 9-session protocol. People saw a therapist twice a week for 4 weeks, in addition to one evaluation session. The people that are enrolled in this therapy, 70% of them ended up either pain-free or at 0 out of 1 or 1 out of 10 pain at the end of the treatment. And almost all of them kept that level of pain reduction at 1 and 5 years later. So for a subset of these people, the pain full on went away. What we think this was people who had nociplastic pain, that form of pain that's generated primarily by the brain and the central nervous system. So it might be more complicated in other conditions, but the model really is, as I've been saying to all of you, your brain can learn to overprotect you, right? That can be because the disease hasn't been well managed for a long time. It can be because pain itself is stressful. It could be because other stressors happen in your life. But once the brain gets turned on to start overprotecting you this way, we have to work specifically on turning it down. We have to work specifically on rebuilding a sense of safety. Okay. That's what's distinct about this therapy versus some of the others that have been done. Right. So to this point, there are no studies of this therapy in lupus. There's also one other limitation, which is when I said 9 sessions in 4 weeks, did that sound like a lot to anybody else? Anybody else have time to go see a therapist 9 times in 4 weeks? Right. Me neither. And I do the work. So with some of our colleagues in the CPFRC at the University of Michigan, we've been running a brief version of this. a 3-session Zoom-based intervention to treat nosoplastic pain. And we just had our first paper published on this, which was in fibromyalgia. So with 3 hours of therapy, we had about a 1/3 reduction on average per person in pain, just from doing 3 hours of therapy. So it was a combination of breathing and meditation and learning to approach pain in this other way and reminding yourself about the safety of your body. And by and large, so what we actually had was about 1/3 of our people ended up with at least a 50% reduction in their pain in 3 weeks. So the idea with some of these therapies is if we give you the techniques and we teach you well how to do them, you'll go out and use them all yourself. It doesn't require nine sessions. It doesn't even require any in-person treatment. So can you all see where I'm going? We're doing it in lupus. So this is a study that's being done with Dr. Bergman's at the back. And we are actually going to look to see if this therapy works in people with lupus and ongoing chronic pain. Okay, so the study itself is ongoing. We've got about 9 people enrolled, but we like to get to about 30. And the only real criterion is we want to make sure that people are on a reasonably stable medication dose. We don't want the disease activity totally out of control because it's harder to know what kind of pain we're treating. It's 3 Zoom sessions and a bunch of online questionnaires, and that's the whole study. So we do have some flyers that are at some of the tables in the back if anybody's interested. And that was the end of my presentation. Thank you.
So I guess there's a microphone. Let me get this right. So I think it's epigenetics, the word, I'm not sure it's where it is, where the trauma cells from your ancestors go on to the children. Is that true?
That's an interesting question. So that is one way it can go. So for the question, if anybody didn't hear that, was epigenetics is the idea that trauma from your ancestors might transfer into your cells. There is some research for that. But the other piece that we think is really important to know is that whatever your genetic makeup is, what happens in your life can modify how those genes behave. Okay. Yeah. So it doesn't mean that other piece isn't there. It's obviously, we like to think that people come in with a clean slate when they're born. We know it's not always that simple. We know it's rarely that simple. Yeah. Hey, yeah. So that's a great point. Yeah. I had this conversation a lot for the record. No, it's a valid point, and the truth is we don't really fully know. Those are hard things to answer because even if we get somebody in a research study, right, we say, well, what's your life been like? What has your stress been like? What's your health been like? We then have to get their ancestors to do it too, right? So it gets hard to study some of that stuff. Yeah. Yeah. Kudos to you for coming up with one of the topics more interesting than anything that I just said in the last 30 minutes.
I have a question about biofeedback. Are you experienced in that area?
I know.
So I've actually started that.
Yeah.
There's only one person in the mission. So he's completed it.
All right. I'll just yell. It'll be fine, right?
Specifically lupus patients that have completed biofeedback. I have about 5 sessions left of the 20. He's done it and he's had huge success, but he's not a lupus warrior.
Gotcha. So specifically, I don't have any specific experience with biofeedback in lupus. I have done it for a lot. I did it for a number of years when I was a postdoc at Stanford. What it really does, biofeedback is just a technology aided way of helping you train your nervous system or train your body, right? So there's a version where we can test your hand temperature, your breathing rate, or your heart rate. And that visual feedback just helps you do it faster, right? So the way it works best in pain is when it's done in combination with things like CBT. So with CBT, the therapy I mentioned earlier, The idea being that things like deep breathing or meditation probably have some of the same effect. So if biofeedback, in some people, it makes it easier to see, it makes it easier to learn some of those techniques. And the other kind of secret sauce to it is that it gives people confidence that they can actually change how their bodies are behaving.
To add to that, they're gonna complete that and then continue on to EMDR.
Fabulous. So working on EMDR EMDR is a therapy we use for a variety of things, primarily trauma, but there are other reasons we might use it. And anything that helps the nervous system feel safer and calmer tends to have a positive effect on pain. Which, by the way, can be things like
Hello, Dr. Sturgeon. We do have a couple questions in the Zoom chat. Can you hear me okay?
I can indeed.
Okay, first question. What are your thoughts on the genome-wide association studies showing correlations with chronic pain susceptibility?
Oh, you guys ask hard questions. Okay. The truth is that what we think is probably happening in most chronic diseases, and that includes chronic pain, is that many people do have genetic vulnerabilities. But that doesn't mean the same thing as it's predetermined that you will have the disease or the disease will forever affect your life. Even if it just means a different starting point, right? It might be that, so there's family, there's like genetic links to things like migraine and fibromyalgia, and certainly rheumatic conditions as well, right? But even within that, a lot of the things you choose to do make a difference. Working on your diet, working on your sleep, working on your exercise, making sure that you're getting good medical care, all of those things still affect what's happening. Genes are definitely a part of it. That's why it's not fully random who ends up with these conditions, right? But don't take that to mean that there aren't things you can do. There's always more work to be done. And genes only tell part of the story.
Thank you very much for that answer. One other question from the Zoom chat. How do you think about balanced exercise when it worsens fatigue? Should you still be exercising if it wipes you out?
That is a great question. We get the same thing, but the question is, so if exercise makes fatigue worse, or if it makes pain worse, should you be doing it? The answer is generally yes, but probably at a gentler level than what you're currently doing. So the first step in exercise, this, by the way, isn't even chronic pain. Right? If you go into the gym for the first time in a year, you push yourself way too hard, what happens? It hurts a lot, right? Because your brain is accurately saying, we can't handle this, right? So it's the same thing in chronic conditions. If you have chronic pain, you have chronic fatigue, physical activity is important for reducing inflammation. It changes the health and the strength and the flexibility of your body. It also changes your brain activity. So we do want you to still do it. It just means finding small, safe doses of it to start with. So if 30 minutes of anything is too much for you, try 10. Every little bit of exposure helps. I've had people tell me they went from just a minute or two of exercise up to an hour. And by the way, there's no magic number, right? It's not that you have to exercise an hour a day. Let me assure you, if that were the case, a lot more of us would be in pain, right? But it is a thing that helps move you in the right direction. So the same is true with fatigue. And if you're not sure, by the way, if you're worried about the health of your body or your ability to do those things, talk to your doctor or talk to a physical therapist. There are things that there are people that can help you decide what's suitable for you to start with. Okay. I'm going to steal from my PT colleagues. They say, start low, go slow. It's one of the best models we can use for pain management, especially with exercise, especially if it's chronic. I think I answered it, or I just said a bunch of stuff. Yeah.
Okay. I'm a therapist. I work at the DBT Institute. Have you ever heard of any studies with chronic pain and DBT therapy helping?
Yes, although they're small. DBT, for those that don't know, is dialectical behavioral therapy. It's a therapy that sort of combines CBT and mindfulness and sort of other techniques that help you address like interpersonal challenges. It's used really for conditions like chronic PTSD or conditions like borderline personality disorder. What it really does is if people have really overwhelming emotions, they have a lot of difficulty regulating those things and it gets them into a lot of trouble. DBT is a great way to calm the system down and help people start to function in their lives in a way that doesn't hurt them. Now, there is some research, and for a subset of people with chronic pain, particularly those with chronic trauma, it probably has a really good effect. But the research is really underdeveloped. There's just a couple of pilot studies that I'm aware of. And they show a positive effect, but probably for the reasons that we're talking about, right? If you go through DBT and it's successful, your relationships are better, you're way less distressed. And if you're less distressed, the brain is less stressed too. Yes. Yeah. The dirty little secret for a lot of these therapies is that they share a bunch of different components with one another. Everybody likes, my colleague likes to say psychologists would prefer to use somebody else's toothbrush than somebody else's name that you use the same name for a therapy. But a lot of the stuff is similar. Was there a question over here?
I know you mentioned earlier, forgive me if I can't remember the name, but those who I think in that study have received some type of relief and they continued it. So my question is, as a warrior with fibromyalgia, when I've had physical therapy,
yep,
I don't receive the relief until I do the TENS unit with the piece. Yeah, and then I may be able to walk out a little better than when I walked in. And that may last 10 minutes, but it's the best 10 minutes ever. What's going on?
So TENS units, you guys need to talk to a physician or a PT more than you need to talk to me. TENS is a great thing primarily for what it seems to be doing is it's modulating some of the signals between, say, a muscle group and the brain. So where the research seems to support, last I checked, is that it works really well paired with things like exercise or PT. So what it's really doing, you all heard of things like spinal cord stimulators, same idea. Remember, pain, even if it starts here, it ends up here. So things that change that signal from that site of injury or the site of where the tissue is compromised to the brain, that's what reduces pain. What you're doing in PT and TENS is a great base. With fibromyalgia, it might not be enough. It might also mean working specifically on the brain regions itself. So the idea is the brain just might not update as quickly. Even if your body is healthy, the disease is down and your body's stronger, the brain may not register it. Did I answer your question? Okay. Thank you, guys.
Try that again. I know Dr. Sturgeon had mentioned in his presentation things with microphones, and we're certainly having our own microphone issues today. Thank you for your patience. Next, we have Conference Co-Director Dr. Dominique Kinnett-Hopkins introducing our next speaker, as well as moderating today's caregiver panel later on. Dr. Kinnett-Hopkins is an Assistant Professor of Applied Exercise Science and is the Director of the Translational Physical Activity Laboratory. Please welcome Dr. Dominique Kinnett-Hopkins.
Thank you. Hello, everyone. It is my very large pleasure to introduce our next speaker. And unfortunately, she's not able to join us in person, but recorded a session for us today. And so Dr. Rosalind Ramsey-Goldman is the John P. Gallagher Research Professor of Rheumatology at Northwestern University Feinberg School of Medicine in Chicago. She's also an attending physician in the lupus program. Dr. Ramsey-Goldman's research examines risk factors to minimize complications in lupus through national and international collaborations. She has a long-standing interest. Oh, we're starting. We'll try another one. That better? Yeah. Okay. She has a long-standing interest in maternal SLE risk to both mother and child, and was one of the early investigators recognizing pregnancy complications. She is a member of the past chair of the Systemic Lupus International Collaborating Clinics, working on developing disease classification criteria, flare risk assessment, disease damage, and frailty. She was awarded a Department of Defense grant to develop computer programs that helped identify SLE patients and pregnancies in electronic medical records. Dr. Ramsey-Goldman has a longstanding expertise in examining and understanding health disparities, preventable conditions with community and academic input. And she's received multiple awards, including the Evelyn Hess Award from the Lupus Foundation of America, and is a master at the American College of Rheumatology. On a personal note, Dr. Ramsey-Goldman has been my mentor for several years, and is the reason that I have developed into a lupus researcher. So it is great to have her join us today at this conference. So I hope that you enjoy her presentation entitled Lupus and Maternal Health. Yeah.
Good afternoon. I'm so glad that I am here to speak with you today about lupus and maternal health. I'm sorry I can't be with you in person, but I had another obligation. But I'm delighted to be part of the Lupus and You Empowerment Conference. Next slide, please. So these are the objectives that I Now, all of our questions that I would ask, I would ask them with them in the office. So someone might say, can I have a part of this? And we would talk about fertility and construct. And then we would say, what happened to me and my baby when I'm pregnant? So we will talk about baby outcomes, mother outcomes, and how we manage it to make sure that it's turned out as best as it can be. And there are always questions about medications. What can I take when I'm pregnant? Are medicines safe? Are there some that I should avoid taking? And again, we would share a typical patient's journey so that you know what questions to ask when you have this conversation with your doctor. And at the bottom is I thank some of my colleagues who share some of their slides with me that I share you with this. So let's start on our roadmap for a successful pregnancy in lupus. And we'll first talk about the question, can a person with lupus have a baby? Excellent. So on our roadmap for a successful pregnancy in lupus, we're going to be talking about fertility, how to preserve it, how to have a baby, we did not have as many medications to one of them all the time. Yeah. Fortunately, we have other medications now, so we can rely on this all the time. When someone's having a severe blood, some problems do. And this is the reason it's not And again, the setup for this is similar. The bars to the left of the right-handed graph show the women who had taken the hormone, and the bars to the right on this graph are those who elected not to take it. And you can see that if they elected to take the hormone, they were more likely to have a successful pregnancy in the future, though I would caution you that the percentage of successful pregnancies is still pretty low. The bottom line here is that we don't have to rely on this cyclophosphamide medication all the time when the disease is severe, and there are other options that you can discuss with your healthcare providers to see if those procedures might be necessary for you. With interest of time today, I'm not able to go into detail about that, but the important thing is that you ask the question. And this is part of the dialogue that you should have continuing with your healthcare providers. Next slide, please. So are women with rheumatic diseases, which includes women with lupus, are they actually getting the contraceptive they need in order to make sure that they don't get pregnant at the wrong time, and also that they don't expose a potential baby to a medicine that might cause problems for the baby? So this is an example of a study that used information from one medical center over 2 years in 2013 and 2014, women of reproductive age, and it surveyed over 2,500 women who were on rheumatic diseases, who had rheumatic diseases, who would at least be eligible for contraception. It turns out that only a third of them were taking any prescription contraception, and 70% of them were on a teratogen, which would be a medicine that could potentially harm the baby during this 2-year period of time, and that the providers who were prescribing this medication were the gynecologists and the primary care physicians, not their rheumatologists. So this study suggests several things that we need to do, and you need to partner with us as healthcare providers to know to ask these questions. We need to improve contraceptive care, increase awareness of providers and patients. We need to be sure that you have access to this care. And if you have multiple providers, we have to coordinate that care across specialties so that if you should be on contraception, somebody has talked with you about that and discussed options so you can make the best decision for you. Next slide, please. Next. Okay, so let's talk about some contraceptive options. On this slide, we talk about progestin-only options. And the reason why I'm talking about these first is that they lower the risk of thromboembolism, which means a blood clot, which is riskier if you also have the medicine estrogen. It's safe for most lupus patients, and I'll tell you about the one exception in just a moment. But the side effect is irregular bleeding, which usually subsides after a few months. So we'll go through these 4 options now, working from left to right. You can have an implant that gets inserted in your upper arm. This is safe for lupus and for those who also have the APL plus antibody, which is the antiphospholipid antibody, which might increase your risk for blood clotting problems and even obstetrical complications. The next method is the intrauterine device, IUD, which is inserted through the cervix and goes into your uterus. This is also safe for those who have lupus and have that clotting antibody. We move over one more slot to the right, and you can actually take a pill every day. It's called the mini pill. This is also safe for women who have lupus and that clotting antibody. But the last option on the right, the depot shot, is safe for lupus, but you need to avoid that if you have a clotting antibody. So the key question here is to ask if you have this antibody, and if that's not known, you should be tested for it. So that if you choose one of these types of options, you would choose the one that's safest for you. On the next slide, We'll go over these options again, but also several other options. But now we're going to talk about the effectiveness of each of these options. So if you look on the top row, these are the ones that are very effective, less than 1% failure rate. We already talked about the progestin implant and the progestin IUD. There is one more option here, sterilization, if you have finished your childbearing desire. The middle row are those who are moderately effective. So there is a higher failure rate here, not very high, but still present, of 6 to 9%. And here you see that depot shot that we talked about before and the mini pill. But as you look to the right, you'll see that there are estrogen options here if being on estrogen is safe for you, particularly if you do not have that phospholipid antibody. These options include a pill, a vaginal ring, which is a barrier method, or a patch that you would put on your skin. The last row shows the least effective options to use for contraception, and this could have up to a 25% failure rate. And this includes a condom, a diaphragm, monitoring your temperature, or just using spermicide. So again, knowledge is helpful in what fits in best with your personal desires and working with your partner and with your doctors to know what needs to be done for your care during the contraception questions and counseling. Next slide, please. Now, let's say you need emergency contraception. And what I'm showing you here is a safety option that both patients with lupus, with or without that phospholipid antibody, can take. So this is called emergency contraception, or EC. It's only progesterone. It does not cause an abortion, and it is effective for up to 5 days after unprotected sex, but the effectiveness wanes with each subsequent day. And you can even get some of these pills over the counter. Next slide. So now we've talked about fertility and contraception. Your next question will be, what's going to happen to me and what's going to happen to my baby? And so we will go on to the next slide to start tackling this problem. So the overall summary here, and you're going to hear this repeatedly because it is the most important thing to think about as you work with your doctor and think about medications and timing of a future pregnancy. A healthy mother is the first step for a successful pregnancy. It is really important to control your lupus disease before you get pregnant. And I will show you information that when your disease is more active, there is an increased risk for adverse or problem outcomes for your baby. And you need to be on appropriate medication. You need to control disease. And before you get pregnant, you might need to be on medicines that you can't take during pregnancy, but you want the disease to be controlled, and you want a transition period to go from those initial medicines that got you into a lower disease activity state to medicines that you could take during your pregnancy, and then also think about medications that you could take after you deliver if you want to breastfeed. And we will also talk about how you monitor your health and the baby's health to make sure that you can go through all of those transitions with the goal of minimizing organ damage while we're controlling your disease, and then keeping your disease under control while you're pregnant. Next slide. So now we're going to talk about what happens to your pregnancy depending on where your lupus disease is. Is it very active or low active at the time that you conceive? So we're going to talk about this graph in just in a moment. I want to describe how I want you to look at this. So the first thing is that you see purple bars and pink bars. So the purple bars mean that the mother's disease is active. Pink bar means that the mother's disease is not active. And if you look at the bottom of the graph, you see from left to right, different outcomes for the baby. And then when you look vertically, these are the percentage of pregnancies that fit into each of these categories. So when we start with live births, you see that there is a difference between the women who have high disease activity and low disease activity, in that they're more likely to have a live birth if their disease is in the low activity range. You notice you still have at least 70% of the women with high activity having a live birth, but they could have more complications, which we will now go over. So moving from left to right, you see the next set of bars are mortality. Here, the high activity group is much higher than the low activity group, so these babies don't survive. Move one more slot over to the right, you see preterm birth. Again, the women who have high disease activity, that bar is much higher than the low disease activity, and that means the babies are born early. Move one more to the right, and you see the abbreviation AGA, that's appropriate for the size of the baby at the time of the delivery. And here you see the reverse. If the woman had low disease activity, she's more likely to have an appropriately sized baby at the time she delivers it. But then we get back to a potential problem in the last set of bars to the right, SGA, which means the baby is too small. And again, as you would expect, the smaller babies are born in the mother who have high disease activity. So this illustrates to you why you really want to aim for low activity, because that's the best setting for you to have a baby and minimize the complications. Next slide, please. So then what happens to the lupus when you're pregnant? So about 50% of women will have some measurable disease activity during pregnancy, but it's not necessarily a flare, because most of the disease activity is usually mild or moderate, because these women went into their pregnancy state when the disease was relatively well controlled and they had low disease activity. Usually the flare-ups are skin rashes, joint pain, and sometimes low blood counts, in this case low platelet counts, and these are one of the substances in your blood that acts like little plugs, so if you cut yourself, you don't keep bleeding. However, between 15 to 30% of women might have very active disease during their pregnancy, and you saw that that was not a good state for the baby, or at least increase the risk that the baby might have problems. And to identify those women, when you look back at what was going on with their disease in the 6 months prior to conception, you saw their disease was very active, or they had multiple flares in the preceding 12 months, or they stopped their medication. We'll have more to discuss about medication in just a little bit. Next slide, please. So the last thing we want to talk about is the pregnancy itself, and are there any complications from the pregnancy? So when we look at this table, going from left to right, you see there is a column for pregnancy complications. The next two columns compare women with and without lupus and the percentage of time that these complications occurred. And the last three columns, all off to the right, show if there's a difference between the women with and without lupus. So cesarean section is a surgical delivery, and you can see that occurs more often in women with lupus. There's a 70% chance that this is going to increase if you have lupus. Preterm labor is you go into labor too soon. And again, you see that the women with lupus have more trouble than women without lupus, 2.5 times that risk. Intrauterine fetal growth restriction means the baby's too small. Again, occurs more often in women with lupus compared to women without lupus. That's again 2.5 times. Preeclampsia is a condition where you have high blood pressure, liver abnormalities, blood count abnormalities. And this is 3 times more likely to occur in women with lupus. And preeclampsia is can be much more severe and could go into the eclampsia phase where the women can have seizures, and then that outcome may not be good and rarely would result in death. I want you to see that this doesn't happen to every woman with lupus. You see those percentages for the most part are all less than 37%, but you just still need to be aware of that, and this would suggest that you want a maternal fetal medicine or a specialist in high risk pregnancy taking care of you, because they would know the best way to handle any of these conditions should that occur. Next slide, please. So how do we make sure that we are on top of all of these things to make sure that if something is happening, you have the best care? So your healthcare provider is going to assess your lupus disease activity at least once every trimester. They're going to ask you a bunch of questions. They're going to examine you. They're going to look at your blood pressure, which is a VP. They're going to look at your joints and your skin, your heart and lungs. If you have any sores, if you have any lymph node swelling, are you swollen in any other part of your body, to see if there's any hint that the lupus might be active, because some of these areas are also affected just by pregnancy itself. And the strategy is that you need someone who knows how to distinguish what might be just your pregnancy versus lupus. And so if it was lupus, that you would get the appropriate treatment. We're also going to be checking several things from a laboratory standpoint. So we want to make sure your kidney is okay. So this involves blood and urine tests to make sure that kidney function is fine. We're going to check blood counts, and we're going to do some lupus blood tests. Some we do at every visit, like the double-stranded DNA and the complement levels, that's C3 and C4. We've talked about that phospholipid antibody several times. You really only have to do that at the beginning, either just before you conceive or right at the time that we document conception, or that SSA-SSB antibody. That doesn't change. And I apologize, but sometimes that's listed as Rowan law. And so I'll try to explain all this alphabet soup as we go through the rest of the slides in terms of how it might impact what you need to do for your pregnancy. Next slide, please. We talked about monitoring for the mother. Now, what do we have to do for the baby? So fetal surveillance or fetal monitoring can be done with sound waves, where they look at the organs and how they're functioning, and they also measure how much the baby is moving, how big the baby is moving, and the heartbeat. This is especially important in the 3rd trimester, so they want to make sure that that placenta, which is providing all the nutrition for the baby, is functioning properly. And if it's not functioning properly, the baby is at risk for that SGA, or small for baby size at time of delivery, and it may result in a recommendation of earlier delivery than anticipated, because if that placenta fails, that's not going to be a good situation for the baby. In this rare situation where the mother has that SSA-SSB, or also known as Rowan antibody, that can transfer through the placenta to the baby, and in utero, it can affect the heart. And so the fetal echocardiogram is another way of using sound waves to see if the heartbeat is appropriate, and if there's inflammation in the heart, because there may need to be treatments either while you're pregnant or if at the time of delivery. Next slide, please. But the critical question that's on all of your minds, I'm sure, is, okay, you got all this stuff going on when I'm pregnant, before I'm pregnant. How do I take medicines when I'm pregnant? So let's talk about that. Next slide, please. So again, my initial statement is healthy mother is the first step for a successful pregnancy. So we usually need medicines before, during, and after pregnancy to make sure your lupus is under control. Why do we need to do this? We want to control your symptoms before you get pregnant, and also to prevent any damage due to the organs, because the pregnancy itself puts an extra burden on all of the organs and how they work. And we want to make sure that they're in the best shape possible, even when your lupus is now quiet, to be able to support a successful pregnancy. So the medication choice here is critical for both the mother and the baby. And we're going to review what we can and we can't take during these 3 critical times before, during, and after pregnancy. Next slide, please. So I'm going to show you a number of tables that are color-coded. These are from the American College of Rheumatology guidelines from 2020. We have some newer medications, but we'll focus on the ones that are in this slide, and you would know that, are there any other options? Again, asking important questions. But this is the basis from which all of the counseling will occur in terms of medications. So if you see things in green, that means that they are accepted. And so you'll see there are conventional medications that your doctors can use, and there are, and the ones in the top part before you get to the white row, and 2/3 of the way down, that show, that are usually used in lupus. The ones below the horizontal bar, the bottom third, really the only medicine that is appropriate is the bottom one, which is rituximab. So here you see that there are a number of choices of pregnancy-safe medications that you can take. Next slide, please. So I'd like to become pregnant soon. What should I do? So we're going to start talking about now medicines that may not be safe during pregnancy. So these include methotrexate, mycophenolate, leflunomide, cyclophosphamide, and several other medicines, warfarin, which is if you have blood clotting risk. Those funky initials, ACI, ACEI, and ARB, relate to certain blood pressure medicines that are used to control blood pressure and protect your kidney. And then thalidomide, which is used for skin. So if you know you're on any of these medicines, you can see that there's already an instruction to delay contraception. So you want to consider pregnancy-compatible medicines and counseling. They will probably say start prenatal vitamins and start establishing OB care, and consider going to the high-risk specialist for your preconception appointment to make sure you're doing everything that's going to ensure to increase your success from their standpoint. And as you can see, there are other things that we can do with some of these medications to enhance the chance of success. Next slide. But sometimes you find out, oops, I'm pregnant and I'm on these medicines. You can see the big red stop sign there that you need to immediately let your healthcare providers know that this is and this has occurred, and you have to have a discussion about what to do next. So you do have the option of considering pregnancy-compatible medications. If you haven't started the prenatal vitamins, do that, and make sure you have an appointment with the high-risk doctors. And there are some additional interventions to minimize the potential problems with these medications. So control the disease with safe medicines, so that we know that you're going into your disease with your pregnancy with low disease activity. Make sure you have an experienced team before pregnancy. You have to have a trusting and open relationship between patients, between you and your team. And I want to refer you to the lupusinitiative.org. This is a website from the American College of Rheumatology done by the Collaborative Initiatives Committee, or COIN. I was a past chair of that, been involved in writing and providing a lot of these materials, which you will find helpful in helping you get your questions that you wish answered, so that you can work together with your team to have a successful pregnancy. Thank you.
By blending her background in public health, as well as her practice of yoga, she creates a safe and inclusive environment for all. Please welcome Shakina Russell.
Hello, everyone, and good afternoon. How are we? Awesome. Okay, so we've done a lot of learning, right? Now we're gonna move a little bit. Again, my name is Shakina. I am a certified yoga instructor. I also teach Pilates. Is it okay if I turn on the light?
Yes.
Awesome. I'm also a trauma-informed yoga therapist, right? So what that really means is I like to prioritize people listening to their bodies and listening to themselves, right? There are things that might look different for one person than it does for the next. There are times when your body can balance, and then there are days where my body cannot balance. I don't really care what I ask you to do, it's just saying no. And so we vary from day to day. Our capacity might vary from day to day. So we incorporate and we bring all of ourselves onto that mat every time. Everything that I will do today, you will be from the seat. Everything that I would be doing today, depending on how heavy your jeans are, should be pretty accessible to you because that is the goal. I did bring music. We'll see how that goes. So hopefully it goes pretty well. And it's just light music to kind of get us into the thing, right? Give me one moment. But what I would like for you to do is to prioritize in this moment is finding the comfort in your seat, right? So finding space, finding the ability to move, maybe pushing back from the table just a little bit, not too much. Well, there we go. We're right into it. About 30 minutes of stretching from our chair. So now that you found your space, I want you to kind of lift one cheek and then the other slow, loud. And really plant firmly in your seat. Notice your left foot planted firmly onto the ground beneath you. Notice your right foot planted firmly into the ground beneath you. And maybe you take your hand and you sit your hand on your lap. If you have the capacity, if you have the space, if you feel this still safe to you right now, maybe you gently close your eyes. Really acknowledging that there's nothing additional for you to do in this moment, but to simply be present. Notice your breath, your body. Does your breath have a texture or indicated fast right now? Right? Or have you found that place of ease for your breath to take it forward and slow? And as we move ourselves from our breath, notice your body. Nothing for you to change, right? But just acknowledge your posture as it is, as you are. Acknowledging your shoulder, the weight of head on those shoulders. Working your way down your spine, hips. The back of your body, how is that today? How are your feet? Most importantly, how are those little baby toes? Right? And as you acknowledge, as you notice, as you take stock of where you are in this moment, I invite you to take a nice big breath in through your nose. Open your mouth, HA a bit. There's something beautiful just with being able to sigh and release and to let go. And so I invite you to do that again. Let it be for both. Let it be in through your nose. And exhale. And because that feels so great, we'll do it a third time, of course. Slowly, gently, and pull, and out. Let's fight a little bit more gentle. A little circle around your head and neck. Just moving around your body. It doesn't have to be big. It doesn't have to be bad. It just has to be big. It really doesn't matter the direction. A lot of being trauma informed is realizing that there are just certain things that don't matter. So wherever you were, let's take it in the other direction. Take your time. There's no rush. We're here, it's now. Two more time. And one more time. And then bringing that head all the way back up to center. And take your right ear and let your right ear lean toward your right shoulder. Good. In through your nose and out through your mouth. One more time for us. In and out. Now let your head fall back. Not too much, a lot, as much as your body allows. Take it in and out. Left ear, left shoulder. Something good about being intentional about these movements. Find your inhale. Let it go. And now chin to chest. Really feeling it along the back of the body. I know for me, this is where it's at right now. Breath in. Big. Beautiful. Through that all. Maybe gently open your eyes. We're going to work our way from our head down to our toes. Okay? And so from our chair, and we'll just try it. Lift your hand. Right? And this looks different for everybody. Or you're here, or you're here. As long as you're lifted, as long as you're trying to do it, then we are successful. So when you make fists with your hand, the tightest fist, really tight. Tight some more, right? And I'll let it go. Let's do it again. Make a fist. Really squeeze, squeeze, squeeze. And let it go. Bring your elbows back with your arm. Same thing. Tight fist. And release. Yeah. And tight fist. And but I want you to leave your right hand in, your right elbow in. I want you to lift your left. Almost like you can touch the sky, you can touch the ceiling. If you wiggle your finger, you make a circle with your wrist. Yeah. Then let's switch. Wiggle your fingers, it's circles with the wrist. Good. Then we'll switch again. Imagine maybe you're climbing a rope, climbing a ladder. Whatever really paints the visual in your mind's eye. Grabbing and pulling. Grabbing and pulling. Kind of combining our movements. Yeah. We'll take this for 3. I'm counting down for 2. Counting down. Practice those arms. Open up those fingers. That's it. Right here at your breath in and out. Come on, in. All right. Look at your shoulders. Give yourself a chin. Okay? Y'all were real serious here tonight. Okay? So let's loosen it up a little bit. Roll your shoulders back. Yeah. Then a lot of times I'm like, oh yeah, she's gonna take my yoga class. And I'm like, oh no, can't yoga. I'm like, you really can't. You really can't. And now let's roll the forward. Yeah. That's my most favorite song of all my yoga players have a lot. Forward again. We'll try some gentle cat cows. I like cat cows because they get our bodies and our minds associated or used to associating breath to movement. So take your hands and put your hands on your knee. Right? And this movement we've been used to doing. So when you inhale, I want you to let those shoulders roll back, your head roll back. And when you exhale, I want you to press your shins away from you and roll the spine. Chin reaches toward each other. Okay? And then inhale. Let shoulder blades touch the back of the body. And exhale. We'll continue to do this for a little while. Just matching breath to movement. And let it be as slow as you want it to go. Let it be as fast as you want it. Cat cows really help to bring movement into our spine and the back of our body. Right? It allows it to stay a little bit more limber and simple. Take it for like 5 more breaths. Just feeling into ourselves. I'll call this 3 more breaths. Oh. Let this be our last one. Come back up to that neutral spine, relax your shoulders, bring your head back up. Let the crown of your head be nice and tall. Right? So how are we feeling? Okay. Ready to move to legs? Yeah, okay. Somebody looks skeptical back there. I saw you. It's okay. I believe in you. So again, we're planting our feet into our neck or into the ground. I'm so used to being on the neck. We're grounding. Your hands can be clasped at the bottom of your chair if you'd like a little bit more security. Your hands can sit at your side. They can be at the arms of your chair. I like my hands clasping the bottom of my chair. Okay, I'm gonna take my shoes off because I am that way. I can't help it. So plant firmly into the bottoms of your feet. And I'm going to take your right leg. This requires a little bit of space, but lift your right leg. Lower it down. See, not so bad. We'll do it again for those of you who are skeptical. Lift it again. And lower it down. You might be wearing shoes, but wiggle your toes. Let them move around a little bit. They might not have the space you want them to have, but it's okay. It all counts. Okay? And now plant that right foot back firmly. Lift your right leg. Leave it right there. Point your toes. And now flex. One more time. Point. And lower your foot down. Really good. We'll lift our leg. Point our toe. Flex our ankle. Pull down. Yeah. It doesn't have to be that. Take your time. Right? I know sometimes I have a tendency to just move for no reason. So lift your leg at your pace. Point your toe. You flex. And then you lower. And I'm going to count us down from 5. That doesn't mean that you do 5. That just means I'm counting. Right? Gotta stop somewhere. 4. 3. That's 2. And 2. Done. I'm going to take the same right leg. Now this is a bigger move. Maybe cross your right ankle over there. Yeah, and it's okay to put your body where you need it to be. Touch is absolutely welcome. Take one hand to the top of the knee. Take one hand to your ankle, and we're pressing. We're pressing at the top of the knee. And you'll start to feel it in your right hip. If you feel it a lot in your right hip, back off. Why are you doing that? Right? Let it go. But if you want a little bit more, see how it feels. Press. This is all experimental. And a lot of yoga is about understanding what your body likes and doesn't like, understanding the habits of that your body has developed, right? It's not necessarily about can you do these big moves. It's about getting to know yourself in that way, right? We'll press it one more time. Good. All right, and when you take your hands with your hand, leave your leg crossed if you like. Otherwise, it can still be planted. Take your hands behind your head. Elbows nice and wide. And we're just gonna hold it right there. You can fidget, you can move, whatever helps you stay right here and grounded. Or you open up your chest and move your head back. Hold it for 3. That's 2. And all the way back. Center. Release your hands, release that leg, let it land right back to the ground. Remember those toes? Wiggle your toes. Feel your feet on the ground. Okay, shake out those shoulders. Shake out those legs. And let's ground once more. We got our left leg. It's the beauty of having 2 sides to yourself. Okay. So same thing, same difference. You can grab onto the chair, you can grab here, you can settle your hand. But I want you to lift your left leg and lower. We'll take it 5 small. If you want breath, it's inhale to lift, and it's an exhale to lower down. You like that. Last one, inhale to lift. Exhale to lower down. Right? Let's lift our leg one more time. Point your toe and flex. Same difference again. Point and flex. Lower it. All right, this is where we found our rhythm. Recall, we lift our leg. Point. We flex. We lower. Yeah. Let's find our rhythm again. Again, it's your pace. This might look a little bit slower for you. This might look like you're running for others to see if you can do it all. Okay. But I'm going to count us down for 5. And 4. 3. 2. And good. Plant your feet into the ground. Again, shimmy, wiggle, move, fidget. All of you is welcome into this space. And I want you to take your legs and take them a little bit wider than you have. Right? So think big feet, right? We're gonna do a forward fold. And I know you're like, gee, okay, but it's absolutely possible. So scoot your chair back from your seat, or you fold until you put your head down on your table. That's your choice, okay? So I want you to inhale, lift those hands. Okay, for me, since I have a lot of space, and you have a lot of space, your fold can look like this. When you fold forward and touch toward your toe. For those of you who have the table, I want you to fold forward and just simply put your head on the table, right? Let your hands, your palms plant under your forehead. Good. Now on your inhale, I want you to lengthen halfway, a nice long spine. And on your exhale, fold back. And be mindful of the things around you, of the space, of the tables. I want you to make this the safest fold that you can for yourself. We'll do that 2 more times. Inhale, lengthen. And then exhale to fold. We'll do that 1 more time. Inhale to and then exhale to fold. Now in this forward fold, we're holding right here. I want you to tuck your chin toward your chest. And I want you to let it the slowest roll all the way up back to your seat. End by end, centimeter by centimeter, until you're all the way back. Here. Okay. We're gonna close ourselves out. We have just a few more minutes. And so I want to get in some twists. Yeah. And a little bit of a side bend. Yeah. Okay. Take your right hand, grab for the bottom of your chin. Take your left hand and lift it all the way up. Take your left hand and lift your right. Yeah. There you go. That's that side bend. Now maybe you stay right. Maybe you lift your gaze up toward the ceiling and get a little bit in that bend. 3. Breathing. 2. Breathing. And 1 all the way back. Let's switch hands. This time our opposite hand grabs to the bottom of the chair. Opposite hand lifts, lean all the way over to the side. Good. Now it's always our eyes. Notice that when you look up, what that does to your chest and your body. Like how it opens up your heart. 3, 2, and 1. Listen. Lower everything back. And when you let your hands come forward, make the fists, ball them up and over. Ball them up and over. I think we have some stretch balls back there. This is good for them, right? You have them. Okay. Now we're gonna do our twist. Take your hands to heart center. I know you've seen this yoga pose a lot. Take a breath in through your nose and out through your mouth. Again, in through your nose. And exhale, twist toward your right. Yeah, just like that. Good. And inhale, come back to seat. We'll do it again, back to movement. It's an exhale to twist. Almost like you're wringing out all the air. And an inhale when you come back aligned. Last one. Back to center. Again, per usual, let's shake it out. The best shoulder movement you can get, right? Bring those hands back to center. We're going to twist to the opposite direction. It's 3 of them. It's an exhale to twist and bring out all the air, and an inhale to level set your body. Again, exhale. Inhale. Last exhale. Beautifully done. Let your hands rest upon your body. It can be at your heart, it can be at your side, it can be on the table. Okay, let's find that place where your eyes gently close. And if you don't want to close your eyes, just bring your gaze off it to your nose. Find a place where you feel comfortable, where you feel centered. Big breath in through your nose. Big breath out. Again, intentional breath. Bring your hand back. Maybe set an intention for the rest of this day, the rest of this conference, the rest of this Saturday. Whatever that intention is, I want you to bring it to your mind. Right? On your next step, in through your nose, breathe in that intention to your mouth. And on your exhale, let that intention surround the air. Let it. Now, as a community in, as a community, we exhale. And as a community, we. Thank you, everyone.
My name is Eva. It's been an absolute pleasure to practice with you.
Great, thank you so much, Tia. I hope that everyone's feeling a little bit more relaxed. I enjoy that little 7-minute stretch. Please note that Shakina is also one of our yoga teachers for the Lupus Health Coaching Study, which you can learn more about in the room next door. But other than that, we're going to go ahead and take our last break before the caregiver panel starts at 2:20. This would be a really great time to request that party validation at the front desk. You can have it already. Check out those vendor tables. Thank you. Hi, everyone. May I please have your attention? We're going to get started with the panel now, and I will pass things to Dr. Dominica Hopkins.
Hi, everyone. I'm Dr. Don, assistant professor in the School of Kinesiology, working with the study of human movement. And I'm also the director of the Translational Physical Activity Laboratory. And I wanted to just take a moment to appreciate all of the work that we have done with our Lupus Cab, help inform some of the research program that Rachel and I've been working on through her. And just want to take a moment to celebrate and give a round of applause for all of the dedication helping us move research forward and making sure that we continue to do so by involving the community and increasing lupus awareness. So just thank you so much. Part of that community outreach is understanding that, there are a lot of people who are impacted by lupus. And so we are really thankful for all of our caregivers on our panel today who will share a little bit about their journey. And so to get started, I will ask if you all would mind introducing yourselves and kind of the decision to participate in today's panel. Can you share a little bit of insight into that? Another mic, but I'll start.
My name is Lynn Holmes, and one of the reasons why I love coming to these things because it's informative. It's informative for me, and it also helps me understand more about what is needed in your care.
Hello, everyone. My name is Anthony Thompson. Okay, I want to learn what I can learn, share the information that I have about what I go through every day with my caregivers. Hello, everyone. I'm Jane Brookley, and I'm starting to say I appreciate wearing my suit. Because family members, relatives all together, and I just want to spread the news and let people know more about this community and everything made to make people good and more survival for them.
Good afternoon, everybody. I'm Shabazz Ford, and I always like to attend for the learning opportunity as well as the fellowship, because a lot of times you think that you're going through something and you're the only one, but we're all going through it different ways. So it's good to be able to identify that, and not only myself, but everybody who's around me.
I had to make sure. My name is Antoinette James. I am Christina Hayes' mother, and her caregiver when I am needed. Why am I here today? Because of Christina and our journey together. And I realized through Christina and even my own story and my family that there is power in storytelling, as Shabazz said and everyone else, to learn and relate and just be encouragement to others. That's all.
Thank you so much. We are so fortunate to have you here with us. I'd like to first start off by asking if you could share a little bit about your caregiving journey, and specifically, how did you become a caregiver to someone with lupus, and what was that transition like?
Well, my journey started when Shannon was away at college. It was the weekend that Princess Diana was in a car accident, and that was the day that we went to the ER. But it started about a week before because her friends had called me and said she was tired
you know, and Shannon was just like, I just don't feel good. They brought her home. They had to bring her home from school. And, went through the ER and, that's when our journey started. And it was, been over 25 years now. So we have, been from the lowest to the highest. And I can appreciate all of the, taking care of Shannon has made me more aware of lupus, what it is, how it affects people different. So it's been a journey. I can appreciate everybody here because we learn. So that answers your question. Sorry.
No, thank you.
Well,
You need a, our wife's name is Unique Son. And, we call her Cookie. We've been on this journey for the last 8 years. I have to say that it helps you learn how to have patience. And you have to understand that it's very important to communicate. It takes us to be a team. It's very important that the man listen. The more that he listens, he get a chance to find out what she really going through, what she needs. That's what I'm learning, that I don't need to talk. Just shut up and let her tell me exactly what it is that she needs done, because no matter how I feel about what she needs. And we gotta realize you must have empathy. Empathy is something you have to have because you don't know what the woman is going through. And she needs you just to be there for her, to listen to everything she's going through. A lot of times they need you to hug them, just give them some affection so they can know that you're there for them. And besides that, it's very important to understand that you have to sacrifice your time. Everybody don't want to give them their time. You're gonna be a caregiver, you gotta understand the importance to give of your time, not be crying about I gotta. No, you gotta be a caregiver. If you're gonna be there for her, your time ain't your time no more. That's what you gotta realize about this. It's about that person. You gotta do the things to make them feel loving, and not that it's like you doing something because you gotta do it. No, you doing it because you love them. You want them to be there. You want them to be a loving human being that knows that somebody loves them, not that you got them any form. They don't want you there. They want you to love them, accept them like everybody else.
I kind of feel like imposter syndrome, everybody, because, you know, after hearing previous stories, my dad was very different about 25 years ago. My sister was diagnosed, but I wasn't in Detroit, I was in Chicago. And so my role was more like out in her place to think. Because she didn't have anybody she could talk to, and she was going through different things, but it was just me being. And the thing that was most striking about it, that now looking back, I can see her listening. She was not the same person that I've been. And I blame that on Lupus. And you know, she had many near-death experiences, and one day, you know, that was it. You just couldn't, you know, she was gone. And then a year later, my wife was back. You know, she had, you know, it's funny about Lupus is that they told her she needed fight. You need to work out, you need to do this, you need to do that. And she had a heart condition. And that's when they didn't even say that, like, you might have lupus. So, you know, that became a different journey, and it opened up some doors because we were trying to conceive and we couldn't, didn't know why. Now I see. We finally adopted a daughter, and but 15 months later she's gone. And so I don't have this history of being a caretaker. But what I do have is just this vision of watching them change over time. And it's not their fault. She's a police officer. So is my sister. And she just wasn't that person. So, you know, do I have this history of caretaking? No, because it was taken away from me from that thief called.
Well, let me say, You do, because you still have to take care of you for them. So, my journey started with my wife, Crystal, in 2017. She woke up one morning, she couldn't walk. So the journey started when I picked her up out the bed and carried her to the car. And they had me carry her back out of the ER because they said that it was mental. And I carried her into a couple other appointments after that, and they said it was mental. And she needed to go see a psychiatrist, psychologist. So it wasn't until actually going to a physical therapy and till one night she just fainted, getting up off the couch. She started to actually get a little stronger, but then one night she fainted, and that's when the turbulence started, because a trip to a hospital on a Friday night turned into 4 to 5 months in the hospital. But just being a caregiver, I feel like started before the illness, because I was already devoted, but when that came along, I just knew that it was something I had to be there to support her, to love her, to make sure that we could still keep some kind of normalcy for the family through it all, and to understand that I had to meet her where she was at. And in meeting her where she was at, that means I had to do a lot of digging to understand and have grace and patience. And I'll just touch on this one example of what I mean when I say meet her where she's at, because they had to put her on a respirator after a couple of days of being in the hospital. So she couldn't communicate, but I could tell she was frustrated. One, Crystal, I've known her since we were 15. She doesn't curse at all, but she gave me the middle finger. And I knew she wasn't angry at me, but I was shocked. Oh my God, what are you saying? But anyway, she couldn't speak, and I understood that. So I was just sitting there, and I had to figure it out. And I told her, what we're going to do, we're going to write this out. So when I get to the letter, every time I get to the letter that you need me to write, I just need you to tap my hand. And the first thing she told me was, don't let nobody see me like this. But after that point, we were able to communicate. I was able to cuss people out and tell them she don't want me to do it. So ever since then, even though she can speak for herself now, I find ways to communicate and understand.
My journey as Christina's caretaker began, as she said 18 years ago. She was I believe, a sophomore in college at Eastern Michigan University, and I just remember going to the doctor and they're telling us we're going to see a lot of white coats. And white coats we saw not only as doctor visits, but Christina got to speak to a lot of residents and those who were in medical school to hear her story as a lupus patient. So Christina is a little different. I saw a lot of resilience. Christina never gave up. She was very defiant. I could say, no, Christina, you don't need to go. Did you talk to your doctors first? And she would say, I don't need to talk to my doctors because I'm going to go. I recall her leaving to go live in Atlanta. And I said, Christina, Atlanta, that's too far. You're not going to have your doctor. She said, oh, your parents will be there with me. And sooner than later, I got a phone call that Chris was in ICU with heart failure. And so I've seen Christina go. Our journey is like being at Cedar Point, I say. because I've seen her dreams and visions and everything she wanted to do come true. I've been her photographer everywhere she wanted to go. I thank God that I could. Sound great? Sounds like rain. Try that one. But one thing I've learned as a caregiver for Christina, is to one, just be there. To listen. I think that's what I've heard everyone here say. Learn how to listen, not only with my ears, but my eyes too. Because sometimes there's things she doesn't say, but I see. So I've learned to do that and just support her along the way, no matter what it looks like. Christina has a drive that I've never seen, but it's also been inspiring for me. So I just learned to buckle my seat up and let's take a ride. So that's what I've learned as being a caregiver with Christina. Thank you.
I'm, you know, having Lucas can present with some challenges and also for challenges that you all navigate in trying to support those with Lupus. Can you talk about strategies that you found the most helpful in being a caregiver that maybe other caregivers can benefit from? Tools in your tool belt or, you know, approaches to managing the unpredictability of Lupus? There we go.
That's a hard one because there's so many different ways. Just like being a caregiver is just like being have a person with lupus. There is not one set way to deal with things. I have learned to roll with the day and roll with the minute. I lean heavily on my family. I have great family support. I lean heavily on my church. They are phenomenal. And my community as well, and the lupus community. If there are things that I don't understand, I will ask. If there's things that I think that is needed, I will search out and I will find it. As a caregiver for my journey with Shannon, she has a quiet strength. She's not going to really verbalize it, but I can see it in her eyes. I can see it in her determination. I have learned to notice that she doesn't want me, Mom, or Shannon, how are you? Or I've had to learn how to look at her as the other mother has said, and notice, okay, this is where I got to step in. This is where I got to step back. This is what we need to do together as a family. And then sometimes I just have to put my foot down and just say, no, this is what we're going to do, because she never wants to go to the emergency room. Never. And she has been hospitalized as well with some very serious conditions. She as well has been in intensive care. She's got paresis treatment. When she first got diagnosed, they didn't even know what it was. We were going back and forth. And I think I shared this before. My mother was a nurse. And at the time Shannon was sick, my mother was battling breast cancer. And Shannon's younger sister was also having battling a really rare form of ovarian cancer. All this at the same time. So when Shannon was diagnosed, I was crying. Oh Lord Jesus. Big. And my mother went to the bathroom and let me cry. And she looked at me and asked me, are you for real? And I'm like, yeah. She said, so you get up because you got things to do and you got a person to take care of. And I was like, oh, that kind of shocked me. But my caregiving experience, my mother taught me that. My mother showed me what you need to do. Put your foot down, and doctors are people too. They don't know all the answers. So when it comes time to things, as a caregiver, if you have a question without overstepping, you have to ask, like I said, Shannon, it's okay, I need to ask this question.
is this what, what I need to do? Because they can look well and just be as sick as anybody coming and going. And sometimes the doctors, they don't see that. Shannon is, I said, I give an example, we went here. And then the doctor was just, well, she's gonna go, we're gonna let her go home. I was really nice and I said, excuse me, I just need to ask a question. Can we just wait for a minute until her blood work comes back? Because I know Shannon's condition and her blood levels and things. And I said, do you mind if we just wait until her blood work comes back before, you make that decision? Understand you're the doctor, so. And they were okay here. As soon as that blood work came back, oh, we're getting ready to admit her. And she was in the hospital for a while. So, being a caregiver, for me, as it was saying, I'm never resentful. You can't be resentful. You can't go this journey and have any kind of resentment, or I've never felt like my life was passing me by. If this is kind of strange, but for me, it's been enriching for my whole family. Because for one, you really don't understand how blessed you are or how walking every day. And if you have a cold, you get over it in 2 or 3 days a week. But with people with lupus, when they have a cold, that's a serious condition. You going from it, it'll take at least a month just for them to feel better. So it's just learning the person that you are with, what they need. Everybody is different, but all of us up here have said it's about communicating, learning the person who you are with.
Well, my wife has had 83 surgeries. So when it comes to my wife, it's very difficult. A lot of the doctors, if she ever at the hospital by herself, some of the doctors talk harsh to her. So a lot of times you have to have a companion there with you. Right?
We're down the run.
You have to have a companion with you, because I know that the strategy I use is that when I be there with my wife, I have to do like Miss Lynn say, when the doctor come in and get the talk, I have to let the doctor know this. She is not like 99 other patients. She is different because of all the service she's had and all the things that she's been through. So some doctors start with everybody in the same category. You can't do that. Every individual has lupus is different. But one body go through, the other body may not go through. And some of these doctors try to put all y'all in the same category. It's not gonna work. And another thing I went through is that I understand that when it comes to my wife, that I don't try to tell her everything that goes on with the children of the family because she's really emotional. So my experience, it's best not to tell her everything that's going on. Because just like now, I made a mistake yesterday. My little cousin was driving me, killed the lady on 8 Mile. So I told my wife got there crying all night. That was a mistake. Even though I meant well, I shouldn't have told her. Because now she just been going crazy. So you gotta hide things when it comes to that. And y'all emotional. So some stuff you just can't tell them when it comes to the people they love. Because y'all gonna get emotional and y'all gonna react. And that gets y'all body worse. And another thing too is that we gotta understand that we gotta pray. I pray and ask God what we need to do. Because the doctors be limited. They tell you that they can do this, they can't do that. Put it in God's hand. If you put it in the creative hand, everything will be all right. And you gotta have faith. You can't just talk about it. You gotta get that God gonna take care of your body. Because he has got you this far, he'll take care of everything else. Stop stressing. Y'all cannot stress.
So after a couple of weeks in the hospital, a heart condition, Alicia, that's my wife, and I were driving home, and she just burst into tears. I mean, uncontrollable crying. I had to pull over, and she was like, "You gotta leave me. I can't give you babies. You know what? What are you staying with me for?" And I remember looking just like this is like what I'm talking about. This is the deal, you know, that whole veteran warriors thing. And I remember feeling angry about this. How could you say that to me? This is me in my village. You know? How can you think so little of me that because you have a condition I believe you? And I didn't share that with her. But what I'm saying is that, you know, it just, if I can fall back on my old Air Force doctrine, flexibility is the key to air power. And what that means is you gotta be flexible. You never know where it's gonna come from. And you just gotta roll with it. And a lot of it is just that, like, I was angry, you know, but she was in pain. So I had to be in that moment. And to that end, a lot of things, I mean, my wife's lupus journey was very short. You know, from diagnosis to her passing was like a little over a year. So I packaged a lot of that stuff away. And I didn't even think about it because it was the deal. I'm not trying to be a hero. I mean, I didn't even think about it. It was like, if she'd have won $1 million, I would have spent it. So, you know, this was the other side of the equation. This is, I have to be here. I didn't even think anything about it. And one day, her best friend, who was also my daughter's godmother, just said, "You got to take care of yourself." And when she said that, it was the most ridiculous thing I ever heard. It's like, my wife is dying. I will be all right. You're not all right. Okay? And that's part, as far as the strategy. So, you know, you got to take care of yourself. If you're not good, you can't take care of her. So, you know, not go away when you have to, but every once in a while, you got to let that thing out because you only got so much capacity to maintain that.
As far as strategies, I would say, like I said before, I always meet my wife where she is. You know, when she first came home from the hospital, whenever she would stand up, whatever the body needs to regulate the blood pressure was not working, so she would faint. So every night she'd get up to go to the bathroom. I had to trail her in there, you know, once she was able to walk, and I was prepared, pillow in hand. So sometimes most of the time, that led to her laying down in the hallway outside of the bathroom. And it got to a point though where of course it's uncomfortable, but I tried to make it as comfortable as possible. So you're not just falling out on the floor, you're gonna lay down on this pillow. My daughter's gonna walk out of her room hysterical. But I already have it worked out to calm her down. So I just had to meet her where she's at. And like you were saying though, like when it gets rough, you know, you have to show yourself some grace. And you have to understand as a caregiver that even though you want them to be independent and you have to give them that space, you are the foundation. And it's going to get rough. And it's not about you getting recognition, because when you look at a beautiful house, nobody notices the foundation. And it's okay, you know, as long as it holds the house up, the foundation is A1. So as long as I can hold my wife up, I know I'm A1.
Thank you for sharing. For me, I learned by being the caregiver for Christina and also my other children, my mom and my grandchildren, is that who I wasn't when they were young, I grew to be when I was older and when they became older. So they taught me faith, hope, and love. And the greatest of those things is love. Through the thick, the thin, no matter what, Christina's journey and so many other things have taught me about love. And God is my foundation. That one is, when I tell you, I was talking to somebody earlier about the storm, right? But it's not the storm that really is bad part is the flooding that comes after that. So in our family with lupus, as you know, the flares and the unpredictableness, it's like a flood. I mean, when Christina went down, it went down. When she was up, it was up. And I learned to ride the wave with God. I learned the tools for my strategy was trusting in God. I journaled a lot. I did praise and worship a lot in my own house because sometimes we didn't make it to church because I took care of Christina at home. There was a time I was a home giver, so I could stay home. But definitely God, prayers, scriptures brought strategies. My family, my mom, when she was able, has been a great support. I have a twin sister. She was my support. My church was my support. But God has definitely been my anchor. I can't tell you enough, he's been just that person, because my husband, with Christina's situation, and then we were raising grandchildren, right? Christina gets sick, we get a newborn baby, then there's just so many things that was happening, like a tsunami, and I didn't want to take it to my husband, because he was already like, what we gonna do next, right? Because so much was coming, but I learned to go in my prayer closet. There's a secret place we can go and give it all to God. As Brother Tony was saying over here, I can't tell you all enough. I cried in my closet. I prayed in my closet. What I suppressed, I expressed me and God, and I journaled and I wrote a book. So.
Thank you so much. We are almost out of time for our panel, but one of the things that balancing, I should start done. One of the things that was touched on a lot was there are healthcare visits and relationships with providers. I do want to say that if there's ever a treatment or a test or something that you are interested in and a provider says, oh, you don't need that, make sure you ask them to document it in your record that they refused this to you. And 9 times out of 10, you will get whatever test you just asked for. And so I am curious about, and for anyone who maybe hasn't touched on their experience as a caregiver in the healthcare field, if there's other advice for caregivers in their role and any particular thing that a provider has done to include you that maybe you can kind of give us a signal to this is the type of provider we want caring for our loved one. I think, yeah, of course.
Real quick.
Yes, please.
I know we're running out of time, but Christina's rheumatologist is like family right now. It's been 18 years. We had lupus walks, we had lupus events. She showed up with her family. And that I really appreciate. She personally stepped out of her medical field and stepped into our family's life to be that support. And also too, when she was in ICU for 6 months, I noticed Christina would tell me, even though she couldn't talk, she could hear. And me working in ICU, working behind the scenes, I hear a lot of medical staff, and hopefully someone could kind of do something leaving here, is educate medical staff. Be careful what you say behind that desk. Because patients, whether you think they can't hear you, they can. And because of where I worked and what I did, and when Christina told me that, I wrote a complaint. I told the staff, I said, you don't know who you taking care of in here. We are, they look at us like we're, Lupus Warriors, Lupus patients, but we matter. We are people. So hopefully leaving here today, the medical staff, you are here, there needs to be an educational course in etiquette and healthcare. Because our family matters, and I definitely let them know. Thank you so much.
Again, real quick, and forgive me, Sparty, because I never thought I would openly pray anything that had to do with University of Michigan. But this has been incredible. And each time I come here, I have to step out because it affects me so deeply. And today they were talking about trying to have a child, and that was part of my story. So I say to you, don't just dismiss this as just talking here. They gotta do this or grant for them. This is really, really important. And the worst part of my journey is so much stuff that I didn't know. Take all this information and use it. It is in valuable. And again, I'm sorry, Sparky. I just wanted to touch on one of the good things that happened with Shannon. Shannon, everyone was just first diagnosed, was talking about Dr. Josephine Dow. It took us a long time, we could never find her, but lo and behold, we were able to see Dr. Josephine Dow. Dr. Dow was phenomenal in starting her and getting her on the right journey, but Dr. Dow left. We looked up Dr. Dow, we didn't stop. We did not stop. It took us months, almost a year and a half to find her because we couldn't find the right doctor, for her. Found her, she's in Saginaw. Dow wondered how we found her. People go up there twice a year so that she could see her. When Shannon got so sick, it was Dr. Josephine Dow who emailed Dr. Martyr at U of M and told her to she was that sick. Dr. Martyr got in touch with us and told us to bring her there, brought her there. She saw her. Okay, we gonna do everything. Was taking her home. Stop at Whole Foods. Shannon fell out in Whole Foods in Ann Arbor on Washington. So we got her, and from there, I turned around, took her back to the ER. But that has been one of the good experiences. We've had some bad ones, but I wanted to tell you about the and how good her doctors are. About Dr. Rao at U of M. We have never had anything, and I always told Dr. Martin, when you see me coming here with Shannon, and she ain't feeling good, worry when you see me. When you don't see me, everything is okay.
Let's put our hands together for the.
Thank you all so much. And once again, not a dry eye in the house. That brings us to the end of the 4th Annual Lupus Conference. We appreciate your time and we're so grateful for the sense of community that was displayed here today. A special thank you to our sponsors, the Department of Anesthesiology at the University of Michigan, as well as AstraZeneca. Just some final reminders to check out our vendors next door if you haven't already, as well as getting that parking validation at the front desk in the lobby, and also grab this year's t-shirt on your way out before you head out. With that being said, I will go ahead and pass things to Ms. Toya Oglesby. Toya is a Lupus Warrior and the support group leader for Lupus Detroit. Please welcome Toya.
We have had a powerful, power-packed day of information. And so really, I just wanted to come up here and say, that someone said, I don't know who said it, that if you think education is expensive, try ignorance. And we have truly been informed. We have increased and to our attendees online as well, we have increased our muscle of understanding and awareness. And we just want to let all of you know, it didn't cost you nothing but time. So it wasn't that expensive. I want to thank everyone here today. I'm just so full of, we want to extend our heartfelt kudos to all of our speakers, the doctors with all their knowledge and their detail and their fight for us as Lupus Warriors. I'm reading from my notes. I was trying to go off my head. And so I also want to just recognize what a gift this is. we have to extend a special thank you to the PERC team. It was 5 years ago. And Dr. Rachel, we will be forever grateful to you that she because it was her who has encouraged our belief and our resilience of hearing our needs. So many times we talk about not being seen and not being heard. And when we came up with suggestions and listening to us, we said, can we have a lupus conference? And Michigan, they had the resources, honey. They made it happen. And so we are in our 4th year, and we are so grateful because we can take this information and it is bringing healing and it's bringing us a lens of security. We talked about the support systems and it's bringing progress. So thankful for Tiffany. She, thanked our sponsors and the vendors and everything. But the last thing I just want to say is I want you all to go out and be beautiful butterflies or handsome butterflies for the guys. And if you're not a butterfly, then go out and be beautiful or handsome butterfly supporters. So have a great evening.
Great.